back to our last day of the evaluating interventions in the health field. We had covered quite a bit so far, and today I will cover the so-called implementation, evaluation of implementation. And that's a special type of design. It's a variation of what you have learned so far. Remember the cluster randomized design. Remember that step wedge cluster design. Remember all the other variations of it. And this is a little bit of that implementation, dissemination design. After this lecture, I will give you a few examples of how to evaluate um, interventions that are not perfect. But I thought it was important to give you a real example. And I'm going to go for nearly 1 hour, 50 minutes over one specific example here in Brazil of a natural experiment so that you feel like, okay, this is doable. And there are many others we've done here in Brazil in collaboration with UniFest, but not as many as we need in Brazil and elsewhere. We need to evaluate intervention. Remember, if you have a perfectly randomized trial on a medication or a strategy in medicine or any other area of health or a public health intervention, but it's very controlled, very perfectly implemented, the evaluation, meaning everything it's under control of the scientists. That's a what we call a controlled trial. And that's if it's the first time that you learn about the effect of that intervention or treatment on a specific health outcome, then this is so-called an efficacy trial. And I gave you the example of the progression of the clinically randomized study designed, which is start with a phase 1, phase 2, phase 3. You can see clearly the difference between efficacy and effectiveness in that lecture. And you understand that effectiveness is once you've proven your efficacy, then you're going to go a little bit close to the real world, closer. Because even in this environment that you already market a new drug, for instance, in America, typically FDA approved the efficacy trials and a little bit of effectiveness, kind of. Then you launch that, in the country. That means open, everybody can buy, and the physicians can prescribe. Once that medication hit the market, then you have real world events happening and you need to follow that up. And once you evaluate that real world interaction between the people who needs to use, those who needs to prescribe, and the drug that's supposed to be efficacious, then you are in effectiveness environment. In public health, the equivalent of that, as a public health intervention or a major strategy across clinics in primary health care, is something that's never been done before, but you have some control. You have a randomized type of design, maybe a cluster randomized design, maybe a stepwise design that is well controlled. You release the intervention as you wish based on the randomization. You have a more controlled environment. That is your efficacy kind of measure at that point. After you expand that over and you don't have control over it, then you are in an effectiveness territory and you're evaluating that as it progresses, as it expands. That's an effectiveness study. And those studies usually are still control environment, hopefully, but maybe not. And if they are not, they are quasi-experiments. And if you, the scientist doing the quasi-experiment, is not the person who actually controlled the intervention, somebody else is doing the intervention, or you're observing something, or you have retrospective data on this event happening, the outcome of interest, as well as some of the exposure variables in the other confounder, you are in the territory of observation and quasi-experimental design under the umbrella of natural experiments, because it's something that's already happening. You just, a scientist took advantage of that and is trying to measure up and find out what caused the outcome to change. Okay, so this is a very broad explanation. Now you have a different scenario. You have effective interventions. You have efficacious, effective intervention. At least you have evidence for it because you've done what I call meta-analysis, which I'm not going to be able to cover today, given the interest of time. So meta-analysis is a way to simplify, summarize, and do a weighted average across all the different studies. And that way, you can increase the power Remember, the sample size is a limitation. Many studies, you have some effectiveness or efficacy trials were too small, and they cannot show evidence statistically that the intervention is causing a change in the outcome. But when you look at the numbers are staggering and big. For instance, you have relative risk of 2.5, 3.7. However, the confidence interval include the null hypothesis of 1. The value of 1 means the risk on the top is the same as the risk in the denominator, numerator, denominator, the same. So you cannot accept that there is an effect, even though the effect, it's estimated to be 2.5, but the confidence interval is, like, say, 0.9 all the way to 4.7. So you have a very wide confidence interval. Usually that indicates that these studies lack power. They don't have enough sample size. Well, a meta-analysis is a way to agglutinate or summarize in a weighted average of all these different studies, and you extract a little bit of the truth out of that. I won't be able to cover that today because I wanted to give you an overview about implementation, dissemination, design. And this is when you've done all the effectiveness, efficacies, and maybe a meta-analysis is done. Now you say, okay, this works, but how do I actually implement that in my field? So you lack the knowledge to do it. You have an effective intervention, highly publicized. The press is making a lot of noise, but you don't really know how to implement that in your neck of the wood or in your hospital system because there's not enough information there about implementation, about dissemination, about adoption. So just to give you a perspective, if you find that an efficacious drug is going to have a tremendous impact, I'll give you a paper later on, probably is here. If it's not, I'll give you that paper. I'll send to Fred and he'll share with you that prove unequivocally that the most efficacious, most effective drugs sometimes are not the most powerful one because people do not adopt it. Because people who are in charge of prescribing do not disseminate, do not prescribe it right. So something that is, let's say, 80% efficacious, 70% effective, after you disseminate, this effectiveness goes down because the dissemination is poor, and those who actually need in the real world, the people in the community and the cities, are not getting the medication. So the true effectiveness in the population-wide evaluation is only 40-50% of the effect, the original effect. Okay, so that's the reality. You need more implementation, dissemination, research design to evaluate the effectiveness of intervention, at the same time providing evidence that that intervention is implementable, it's disseminatable, and is adoptable. If people don't like the intervention, it's not going to work, right? I'll give an example of an intervention. It's not really a treatment, it's a screening. But do you think people accept to do, sigmoidoscopy easily? Colorectal sigmoidoscopy don't, even today, 30, 40 years later. It's still a very small percentage of people. It's going up a little bit, but it's very effective in preventing colorectal cancer. Okay, so again, it's not easy to implement something that accommodates patient, right? But sometimes it's just ignorance. It's just the means of distribution. A lot of issues, you learn that through implementation, dissemination, design. So here I give you a traditional translation pipeline. This is translation research. You would have, I need to put my glasses on so I can read better. Look at this y-axis here is the real world relevance. Is that really relevant in real world? And here on the x-axis is traditional translation pipeline. This is why we go from a low level of evidence to a high level of evidence. Usually it goes in a different way, like efficacy, effectiveness, that's a little bit of the truth about translation. But the point is, look at the real world, the y-axis. I want that to move up. I want it to get to the point of sustainment of the intervention that's actually shown to be efficacious, shown to be effective. And now I know that's adoptable, and I can prepare the ground, implement it, people accept the implementation, and I can sustain it. This is actually more evident if you take a real example. If you're talking about a drug, let's say a drug for treating a disease that has an expectation that in 2 weeks treatment, you get cured, right? Like an infection and antibiotic. It's going to be between 5 days and 2 weeks time, usually prescription, 90% antibiotic prescription. So you know that you want people to use a drug that's efficacious and effective, right? But also that they accept that drug, that the means by which you prescribe that drug, it's okay. There's insurance, there's a lot of issues, there's access to the health facility, there's reaching out to the patient. And then once this is all implementable, you need to have sustainability of this to get to as many people as possible. More importantly, for that patient, they need to be compliant. So compliance is part of sustainability if I'm looking at antibiotic for a patient at a time. But if I look for something to a population, a public health intervention, we're talking about you do a nice study, you have a grant, and you implement that, but you never worry too much about the mechanism by which you could sustain that. So once the money is over, right, from the grant, the little experiment that was working okay, you evaluate it, looks good, looks like an efficacy, effectiveness type of results, but you have not built the structure to sustain, to implement and sustain that intervention and disappear. That's a complaint of many communities that I faced it when I was the head of the Prevention Research Center program office at the Centers for Disease Control. We gave away over $900 million in money to implement public health intervention that works theoretically. And absolute majority of the community across 32 of those prevention research centers in America, they complained that once the money, it was over, the implementation is gone. Okay, so one of my job for 9-10 years was to push on ways to create sustainability out of those interventions. And I'm proud to say that this partnership generates many interventions. They are sustainable. They're still prevailing in America. For instance, school health systems in America have changed as a function. One big intervention from University of Texas at Houston that we funded for over 8 straight years to improve implementation and translation. So again, this is a real thing. So pay attention to that diagram. So first question when you're dealing with pre and efficacy is that, could this intervention work? Could this treatment work? Does the treatment or intervention program work? That's the next level. That's effectiveness. You say, could this work? I don't know anything about it. It's efficacy. You're in that territory, or in a pilot, pre-intervention, you have some pilot number. Does it work? We're talking about real world now. And now I say, I'm going to create a program, not just an intervention. It's a program. It's a continuation of that. Make a program work. Is it continuously working? That's the real question. And that's the yellow big box on the right-hand side. It's about exploration, adoption, preparation, implementation, and sustainment. And then the dissemination piece is part of this. We call DNI. Okay, in America, it became this terminology, dissemination and implementation. So this is a very nice encapsulation of all that it takes to do implementation dissemination. So you can never separate. So that's why some of the designs I'm going to cover, it's just a survey of those designs I'm going to cover for you. They do a little bit of either efficacy or effectiveness while they're trying to explore and understand what impedes or enhance adoption, what impedes or enhance preparation, what impedes or enhance implementation and sustainment. So we're going out of the territory, pure science, and a lot to do with management and social and anthropological science and political. There's a lot of stuff there too. Depend what the program you're talking about. You can read this, but there's something called EPIS, which is basically the exploration, the preparation, implementation, and sustainment. You can read about it. We can talk about it, all of us. I think the one that should be pretty obvious to you is sustainment and implementation. But let's just the first two. Exploration here refers to whether the service delivery system, the structure that's going to take up that intervention that's effective, or the community, structure behind it would find a particular intervention useful for them. So you need to explore. So about 15 years ago, more than that, maybe 17, we came to Brazil with the PRC, the Prevention Research Center Program Office, and 2 universities in the US, and asked the universities here and the Minister of Health, do you see benefit in evaluating some of your physical activity public health programs? And the Minister of Health said, I have no problem, but we don't have one. They didn't have one at that point. I said, okay. Is it okay if we talk with municipality and the State Department of Health? Well, it helped that I was a Brazilian and I was working in Brazil for many years, for 10 years as a primary care doctor and a public health official for many years before I moved to the US. So I used my connection, call people and say, hey, there's this program here, one in São Paulo, one in Minas Gerais, and one in Recife. And lo and behold, I go to talk to the people in Recife first. That's where I come from. And the Secretary of Health say, yeah, we have this intervention here. Make a long story short, it's an intervention, a group involving me started 20, 30 years earlier and never stopped. They continue expanded. They just changed the name. That's why I could not connect the dots. But it's a program we initiated. And so it was a very effective program. After we evaluated, then we start doing exploration. Say, hey, do you want to import the Academia da Cidade to your city? That was like 20 years ago. So Belo Horizonte say, oh, I already have this program. You're going to evaluate. Yes, I am. But this is a little different. Would you? Yeah, I would consider. Alagoas did. Yes, we would consider. Sergipe say, yes, we would consider. And we start helping to spread, exploring that. Make a longer story even shorter. This program is today a very national, large program funded by Minister of Health called Academia da Saúde, which include nutrition, all those aspects of the program. So preparation is this phase that you're looking into something that's supposed to be effective and trying to get who will be ready to do that. You explore it. And then you have the implementation. The word fidelity, can any one of you tell me what do I mean by fidelity? I effectively evaluate an effective intervention, meaning I've done the efficacy, everything, and the intervention is effective. But if I implement somewhere else and modify too much, it doesn't have the same characteristics as the original, right? So that's called fidelity. I lack fidelity. I don't have the original intervention. And that's a dangerous thing. Some people say you should never change. You're not going to get the same effect. Well, if that is true, for hundreds of years, medicine could never do off-label use of medication. Okay? So that means some adaptation is necessary sometimes. But always pay attention to fidelity, to the fundamentals of that treatment or that intervention. Otherwise, it may not work. So if you say, oh, I adopted the Academia, but hey, do you have physical activity professionals graduated with 4 years of college with a community there, teaching leisure and recreational type of light to moderate physical activity in groups and entertaining? Oh, it's a little different. I don't have that. I have people lifting weight. That's different. Okay. Do you have a physical environmental space that was engineering modified to look nice, to have all the elements that you need, feel people confident in a place that they like, they appreciate, they wanted to go naturally there? No, I don't have that. That's lack of fidelity. So these are the fundamental things. Is that a free activity? The Academia. I'm going to show, why I'm saying Academia, because I'm going to show you an example today of the Academias. Once it was expanded to Pernambuco, and that was the okay for the Minister of Health to create a national program. So that's preparation and implementation. And then you have sustainment that, it's just, how do you sustain this? What are the infrastructure? What are the political organizational will to implement and maintain? So this should be part of this type of evaluation I'm going to mention today. So a little bit more on that. You can read. This is a very nice summarization too of the so-called 5 categories of implementation science. You say there's studies just focus on diffusion, studies just focus on dissemination, studies just focus on implementation, studies focus only adoption or sustainability. I'd say the best study is the one that while trying to do an effectiveness evaluation, you already incorporate elements of what I call diffusion and dissemination, or effectiveness with implementation evaluation. And that's what we're going to talk about, the hybrid designs. Okay? So dissemination implementation can be within site designs and between site designs. with insights can be used to evaluate the implementation successes and failure by examining changes that occur in an organization, in a community, or a system that's supposed to deliver that intervention. So it's usually a post-design of an implementation strategy to adopt an evidence-based intervention in a new setting. It's a post-design. You only need a measurement after. It's not about evaluating effectiveness, it's evaluating the implementation, okay? There's a distinction. There's also with insight that's pre and post. You can do that. You can do the pre and post design, meaning measurement of elements of implementation before you intervene, and elements of implementation after you intervene. Okay, so that's a possibility. Then you also have between site design. This compare processes and outputs, not the whole structure among sites that have different exposures, meaning different sites are delivering the intervention, but they have different exposures to the intervention, different levels or layers of intervention, or degrees of intensity of delivery of the intervention. And new versus implementation as usual designs. Some sites receive an innovative implementation strategy while others maintain their usual condition. Like they only part of the intervention, but they're still the same structure they had. They haven't changed anything. So there's a difference between adapting your structure to intervene as opposed to change the intervention. When you change the intervention, you're losing your fidelity of the original intervention. So it's something you need to be aware of. Whereas when you change the structure of the organization, you're actually adapting it. And you can evaluate that. Some hospitals will adopt a new strategy for aggressive diabetic patient glucose monitoring. Some clinics will adopt that more structurally and modify the infrastructure, their so-called workflow, nurse workflow, medical workflow to accommodate this change. Others will try to enforce that intervention in their original workflow. And there's good and bad in both. So when you have you have an opportunity to evaluate different implementation strategies. You see what I'm talking about? That's between sites. It's not within the site. It's not one site all implementing. Different sites are implementing the same strategy, and you evaluate how they implement, how successful are they in delivering the intervention. So this is really about how do I successfully implement an intervention? What is success? Fidelity is part of the success. Minimum adaptation that modify your infrastructure, your organization, your workflow. It's acceptable if and only if between sites shows that it's delivering better. Okay? Then there's something called head-to-head randomization implementation trial design. And it's very similar to, it's just variation of the team. You have implementation strategy one, like I described it now. One site is very structured. The other one, it's the same as they used to be. They didn't change anything. Just want to implement that. Sometimes it is a problem, especially if your new intervention, which I do a lot, involves a health informatics innovation, a new device, a new app or something. You got to change your workflow because the information is being changed. So some people don't want to change their workflow, and that creates problems. So you have program delivery, clinical prevention. So focus of the research on head-to-head randomized implementation trial with identical clinical preventive intervention and different implementation strategy. We also call a head-to-head randomized implementation trial. So you're still evaluating the effectiveness. Evaluation, there's a difference, another distinction between efficacy, effectiveness. There's something else. Efficacy usually is in a research territory. Why is it a research territory, not evaluation territory, even though say evaluate the efficacy, right? But it's research because it's novel, it's new. Efficacy means I don't know if this thing actually works, if this medication has an impact on infection, okay? In the real world, I tested it in primates, I tested intracellular in vitro, okay? And put my petri dishes there and put them, and it works. But does it work in a human being? What about the pharmacodynamics inside the blood? What about the bioavailability of that drug? But did I do all the studies, the phase 1, phase 2, perfectly? So I really know how much glomerular filtration is going on, how much excreting from that antibiotic is being used up, and the liver synthesizing the other part. So a lot of questions, right? So when you have a situation like that, This head-to-head is another way to say this is not really research. I assume all that research is being done, the efficacy is being done. This is really an evaluation, evaluating if something that's supposed to work actually is still working because I'm delivering right. So I'm evaluating the effectiveness and the delivery by comparing two different strategies in the same system. There's something on the head-to-head. There's all these variation here. You have a more public health. Here's more like a clinic. It could be a public health. So you have, let me read this one. Randomized 40 counties in California to independent county or community development team implementation strategy and time. So you create cohorts as a cohorts, okay, of two groups, the IND and the CDT. The IND is independent county, or the other one is community development team, using a randomized rollout design. So you roll out little by little. It's a staggered design. It's like a step wedge, okay? 11 counties in Ohio were separately randomized in a fourth cohort to the same implementation strategy. So you don't see it here. Here you only see the California counties, but there's another one in Ohio to be like used as another comparator, okay? So just pay attention to that. I want to spend no more than 50 minutes because I have 3 examples of effectiveness evaluation I want to show to you. And they're all in Brazil. So if I've done it in Brazil with support from some of the university people, everybody should think about doing. So here's a little bit of the example of within and between site design. This is a one that combined both within and between. It's a rollout design. Again, remember the rollout? Everybody start as control, and little by little, everybody gets the intervention. That's A over here. You see that? Intervention is X. But here you also have a little bit of variation. And the top is just the intervention X. And here is a Y is a variation of the implementation of the intervention X. You follow that? You also doing that for different cohorts in a little different way. So that's what we call another way to represent that, the one at the bottom, the pair. You can pair, you can match it up and deliver that. So this type of strategy allows you to look not only at drug A versus drug B, but how you deliver drug A and drug B. You need to quantify all of that, okay? If you're talking about a new medical strategy in a healthcare system, think about what are the changes in the workflow and how do I measure that, okay? Oh, no longer goes nurse first. It's going to go first to the doctor and then to the nurse. And so there's a lot of change, so-called workflow in a health system. You need to metrically measure that, see how long it takes, part sometimes, and who does it, what kind of resources being utilized. So you need to quantify that. That's characterized the Y versus the X. It's the same intervention, same medication, but it's being delivered in a different way. And everybody gets both. You see that, how that works? Everybody gets a little bit of both. The cohort A, cohort B, and cohort C. Then there's something called adaptive design. So I show you the head-to-head between design that comparing 2 different strategies. Here you have sequential rollout, like I mentioned, of an sequential rollout is this one on the top. Everybody is 0, then little by little, every point in time, there's sequencing row-wise. Columns are the steps of a step wedge. Remember the lecture on step wedge? So everybody gets that. Sequential rollout of intervention or implementation strategy to individual cluster over multiple time periods. That's exactly what I had here, right? On the top, the very top. Study characteristics change during the study. However, study characteristics changing. That's why it's called adaptive design. Changes in the process are in response to data being collected in real time. So once you collect data in real time, not a posteriori, not later and trying to look retrospectively, but doing real time, you may change because something is happening and you may adapt, you may modify your strategy. That's what adaptive design, but you need to be able to monitor that change. Example of study characteristics include assignment of individual cluster to intervention control group. The design of the study itself may change the manner in which you include the clusters and the individuals in each cluster. You need to document that. Response adaptive design use success or failure result on all previous subject in each intervention to modify allocation. So if something is not going right, you want to change the allocation. You want to give it earlier. You're going to change who gets it. that's an adaptive design that's in response to what's happening at every stage. So here a little bit of those possible, and there are papers on the right-hand side. You can see the last column here, the reference, Whitehead in 1997. This is old, right? 2000. So running prior to randomization, encouragement, allocation. So these are so-called, what is adaptive? So what makes them different than a head-to-head is this adaptation. This first one, it was an early stopping. So there was a design written ahead of time that if something happened, we will stop. That's an adaptive design. Many people do that in a randomized clinical trials too. Optimal dose, reallocation of doses based on estimated dose-response relationship. So dose finding trials. So you do that when you're doing dose finding. You don't know the right dose of that thing. You don't know if it's 10 times a day monitoring glucose or 3 times a day. The recommendation is at least 3 times, but say in between 3 and 20, there's a lot, right? So how is the right dose? So when you're trying to do that type of study, dose finding, now once you efficient determination of dosage, as the benefit, you require short time for outcomes to be measured, confound of dose by entry time, you need to pay attention to that. So you document, you change your design because of reaching what the goal was in optimal dose. But you continue the trial to evaluate the effectiveness and how it's implemented. Okay, so this is just for you to review. Another adaptive design, I think I have too much of it, but arm 1, arm 2, stop trial early is a typical example of adaptive design. But then the arm 1, you stop, but you continue here with another trial just for the people who are in a different arm. Okay, so you start it again. Read it over. There's variation of that adaptive design. I'm going to skip quickly on that because I have a lot of examples. I want to give it to you. Real world. Just wanted to know these things exist, and you should look for those references to understand how to implement such an evaluation. There's no way. The implementation science is a course that we teach at Washington University, not even in my university. We do in partnership. So it takes a whole of maybe 20 to 40 hours of in-class plus X number of hours outside to learn about all this design. I'm putting it all together, 50 minutes to 1 hour for you. So we cannot cover in detail, but there are variations. There's still evaluation of effectiveness that you learn. It's going to be one of those designs, usually a step wedge. Okay? And that's why I say step wedge is the best design for real world situation, because it's never can be complained people too much that is unethical. Everybody gets the intervention. It's real world actually happen like that. I'm going to show an example today. The last hour is going to be a real example we did for the Academia da Cidade. We became the Academia da Saúde. When the Minister of Health took that to the Brazilian Congress, they create the law that creates a budget item in federal budget item to create a new program. They listed the papers that I wrote as justification. So you want better than that as a public health person? I mean, I can die, right? Technically, because I've achieved something amazing, not just me, but the whole team with me. Okay, so that's why this evaluations of adaptation is so important. We did a little bit of implementation science later on, okay, but it was not. That's another situation. You can do an evaluation of effectiveness and later on do one specific on implementation without worrying too much. But you always have to measure effectiveness because you need to at least replicate what we found before, right? Remember, I was trying to say something, I got lost in the middle. Research is when you do a very structured evaluation of an intervention, like intervention research, when you do a very structured, very well designed, very well controlled research or evaluation, that's research, evaluation of something completely new. You don't know if it works or not, if the intervention or treatment works. So when you're doing that, it's research. But once you know it's working and you do a larger one, like in a randomized clinical trial, do an effectiveness, still very controlled experiment, let's say a cluster, a randomized design, very well controlled with all the elements that you may think of, and perfect analysis that you took care of variance for all sources between, within, and attributed to time change. Okay? You took care of all of that. That's still a control thing. But then later on, you need to repeat the evaluation because it's implemented in another place. That's evaluation. That's not research anymore, because you're evaluating against an expectation based on the research. Okay? So evaluation and research are different that way. If I evaluate an efficacious, effective intervention that was deemed to be effective and efficacious based on very well-founded research, but I am doing an evaluation of that intervention somewhere else, it's no longer research, it's an evaluation, because I have an expectation, right? So right now I'm doing evaluation of mammography in Pap smear in the state of Missouri. And the evaluation is very simple. It's a time series type of analysis, a correlated. Why? It's an evaluation, it's not research, because the randomized trials have been done on mammography and Pap smear. I have an expectation. I should be able to detect 90% of the potential early stage cancer for those two type of cancers. And if I don't, if the numbers that I'm evaluating don't show that, that meaning the intervention is failing. Maybe not the intervention, the implementation of the intervention is failing. Okay? Reasons for conducting adaptive design. Actually, this is the reason for error in conducting adaptive design. Usually it's about sample size. I want you to read it because there's a lot of material I need to cover and we need to move quickly. But let me see if I can pull a little bit of that. Most common way to determine sample size, it's you want to achieve a 0.80 power, like 80% power. The second approach is to specify the required power for the trial and use the formula related power to sample size. That's what I usually do. The change in the mean level of the response produced by the intervention and the variability of the measure. So I need to have a lot of pre or pilot or other literature review data to come up with the right sample size. But we may have limited information about the underlying variance, and we can guess it wrong. And the calculated sample size will be inaccurate. It makes sense to use data in the existing study to reassess the variance, thereby modifying the required sample size. That's an adaptation. So when you are suspicious that you do a posteriori, so power calculation is usually good to do ahead of time, but you can do while you're collecting your data and you already have some preliminary results, you can recalculate your power and reestimate the sample size and modify your design. That's an adaptive design based on a sample size, okay? Two-stage approach would allow first stage data to be used to estimate either effect size or alternatively the variance. That's what I do, thereby recomputing an appropriate sample size, including more people. Therefore, I need to modify the enrollment, the uptake of the people should be in the study, involved in the study, okay? Right example, I gave you an example here. Unfortunately, the stuff is coming off formatting, but it's basically a study on historical data on infants. A cohort at one side suggested that this intervention was highly effective with survival rates on conventional treatment without ECMO of 15 to 20%, and a similar patient treated with ECMO was 75%. That's a huge, it's like 3 times, right? It's threefold, 2.5 to threefold improvement. And the ECMO is highly invasive procedure to oxygenate blood outside the body. Okay, it's a machine to utilize. There's a lot of ethical consideration for RCTs versus conventional treatment. So, to reduce the number of babies who would like to die during a traditional clinical trial, where by definition half would receive the poorer treatment. The first randomized trial was a RAD, which used a play the winner rule RAD. Let me show what a play the winner. It's an adaptive design that you modify your design, because if you have a negative event coming out in numbers greater than you expect, you modify the design or you stop the trial. Just read about it. That's an interesting stuff. We're going to move quickly on that, but that's an adaptive design. So every time you hear the word adaptive design, it's going to be the same design I'm going to show later on, the hybrid, but with a special consideration to already ahead of time, you design such a way you can adapt and still maintain the rigorous kind of original parameters measurement in ways that's unbiased. So there are many ways to do that. Subtypes. There's the SMART or the enrollment design. Let's see if I can give you some example. I don't have the others, but I gave you this one, the RAD, which is the typical adaptive design of trials. That's what the RAD was, okay? Here we have the hybrid designs. It's a little bit different, but the same general idea. It's an effectiveness implementation combined. These over here can be just effectiveness and implementation, but adapted, modified. This is traditional effectiveness that you add elements of implementation. So examples here. You have design characteristics, test, typical unit of randomization, typical unit of analysis, and summative outcomes, okay? So design characteristics, clinical effectiveness trial and implementation trial. Test, clinical intervention, you have a test. You also have implementation, intervention, or strategy to evaluate, to have a scoring of implementation or something. I want to show an example later on of a scoring, not adaptive or hybrid design, but it has a little bit of that element. And that's the example I'm going to show at the last hour of this course. Typical unit of randomization, patient or clinical unit, provider, clinical unit. So this is to make a difference between the more traditional clinical trial versus the implementation trial. So a typical unit of randomization in a traditional trial is patient or clinic, whereas in implementation, all is going to be either the clinic or provider or assistant. It's not the patient, it's not the doctor, it's not an individual. So implementation trial is about units that are implemented, okay? So one is called clinical effectiveness trial, clinical intervention, randomized trial. The other is called implementation trial, implementation intervention strategy. Typical unit of analysis, that's unit of randomization. Unit of analysis on the left is always the patient. Doesn't matter if you do a cluster design. In a clinical effectiveness trial, you're dealing with patient. That's your unit of analysis. So in a cluster randomized design, you have unit of randomization being the cluster, the clinic, and the unit of analysis being the patient. And that's why you got a problem, because you got two sources of variance, as you remember, between and within variance, okay? Within variance is the variance between each patient, that means for the cluster, and between is the difference between cluster means, different cluster means. And if you do a step wedge, you may have, depending on how the intervention is constant or not over time, you may have variance coming from the measurement over time, okay? That's another element there. So that's clinical. So all those patients around patient, the main is the patient, whereas implementation trial, both the unit of randomization and unit of analysis are always the cluster or the provider or the clinic or the system. Because you're evaluating whether a clinic A implement better than the other. You need to create a categorization or a scalar measurement or an index of implementation or index of adaptation or index of organization to say, hey, this is doing all right. Right now, I'm evaluating a public health intervention. And the public health intervention, believe it or not, is everything in public health, $300 million to the state health department to be distributed to 115 counties. So I designed a very detailed process and output measure, okay, systems of measurements over time. 2 times, at least 2 times, but ideally 3 times. I'm trying to convince them to do one in the middle. So once I measure that, I'll be able to create a variable, a new variable called implementation variable, meaning successful implementation not, going from 0 to 50. 50 being top implementation. Everything was come by the book. They've done everything right. Timing was correct. Money was not sitting there. In Pernambuco, we saw municipality receiving money, only spending the money a year later because they didn't have accountants to do the right job. They didn't know how to use the money, okay? So that doesn't happen in America, but there are other problems too. So we create a system by which we measure all these in metric implementation. So at a provider level, each county has a metric for them over time. We'll have that. I'm still collecting that data. Then the analysis I'm going to do for the implementation is at the clinic level, because I'm going to look at output for the whole county. Okay? So the two come together, and becomes a implementation type of design. Summative outcomes, health outcomes for the patients. Some process and quality measures may be assessed here, typically considered intermediate and cost can be considered too. But here on implementation trial, we have adoption, uptake of the clinical intervention. You need to measure that. You can measure that if it's a new strategy in medicine, for instance, very simple. You can do interviews, a random sample of physicians in the units implementing that, and random sample physicians in the other units to feel how they feel about that possibility. And you can do exit interviews of patients to learn if something changed in the clinic, if they are old patients or new patients, something changed in the clinic. There are a lot of ways to look into adoption, uptake, process measure. You need to look at money being disbursed, workflow, does it change? How that change? Can we consider that? Can we measure that? So hybrid designs are those that have both the, like I said, effectiveness and implementation design. They're basically, the level of assessments depend on the design type. Such dual foci always state a priori. So if you want to do that a posteriori, that's not right. You need to have that a priori, I mean ahead of time, before you implement the intervention, before you design the evaluation. During the design evaluation, before you implement the evaluation, you need to know this is going to be a hybrid trial type 1 or hybrid type 2 and type 3. Okay, let's go over quickly what these hybrid designs are. The type 1, the focus of that is testing the effect of a clinical intervention on relevant outcomes. So it's still an effectiveness trial. That's the main focus. But then secondarily, I will observe and collect information. Implementation process is a secondary focus. So when you put a lot of energy on evaluating effectiveness, you have less energy in implementation. That's a fact. Okay, in general, the implementation research portion is essentially an add-on to routinely design and powered clinical trials. So you have a traditional clinical trial, and you just add elements of it. So it's more or less like this at the bottom here. The summative outcomes in a clinical trial, clinical effectiveness is health outcomes, but you add may add a little bit of process and quality measure. That's called hybrid 1, type 1. So there should be a strong face validity for the clinical intervention that would support applicability to the new setting, population delivery method in question. You have no doubt that there are new interventions in place. That's what I say, face validity. If something is very confused with the existing status quo intervention, it's hard to discern who is doing the new intervention or not, because you need to make sure that's a fact. There should be a strong base of at least indirect evidence, data from different but associated populations for the intervention that would support applicability to the new setting, population delivery method. This basically, you should have some pilot coming from the place before you do that in a large scale and do a strong evaluation. There should be minimal risk associated with the intervention, include both its direct risk and indirect risk through replacement of a non-adequate intervention. So usually you do that on a mix of effectiveness trial. You don't do that in efficacy level trial because you don't want to test new implementation. So this is an example, study design, patient-level randomized controlled trial, 330 veterans with alcohol or stimulant use disorder in 2 VA hospitals medical center. Okay, so remember, patient-level randomization. So the unit of randomization is the patient. It's not the cluster. It's not the clinic. It's not the system. It's not the provider. It's the patient. And then you add a process evaluation with mixed methods of patients, providers, and manager. So you basically have essentially an efficacy effectiveness trial or one of the other, likely effectiveness trial. It would just add elements of process evaluation, like workflow and so on and so forth. Okay, but you did not design a true hybrid. True hybrid is when you really look at the clinic level. You have many clinics and evaluate. Sometimes you do that. For instance, they only have 2 VA medical systems. They could compare one to the other, one with the new implementation, the other one without it. But they're not doing that. They're just evaluating the uptake, basically, the adoption uptake of the intervention between the 2 VA medical center by measuring some process measurements, see who does better in terms of process and measurement. Okay, this is akin to in an evaluation of an intervention that you know is related to duration, that not only you say a person had the intervention, but had the intervention for X number of minutes. For instance, in many mental health interventions, like mindfulness, okay, it's not only to have a session of mindfulness. If you had one session but did not have the follow-up sessions, you may not get the full benefit of the intervention. If you only had the first hour, not the first hour plus the break plus the second hour of a session of mindfulness, you may not have the full intervention. You still have. So you need to monitor not only had intervention, did not, treatment control. You need to say had intervention and had it for X number of minutes. And the person did follow-up reinforcement and watch a video about that. That's a whole full intervention. Do you see that? So you're measuring all these processes, and now you're doing a hybrid, say it was fully implemented. Some intervention in medicine cannot be fully implemented, especially mental health, easily, because patients do not adopt, do not like it. Okay? So hybrid type 2, remember, hybrid 1 is really a randomized trial, added elements of process and management structure that I'm trying to evaluate. I'm not really comparing different implementation strategies by 2 groups or 4 or 5 groups. Hybrid 2 focuses testing effect of a clinical intervention on relevant outcomes. Still an effectiveness or efficacy trial. That's the main focus. But you test the implementation intervention strategy. Here, you're just measuring on hybrid type 1, you're measuring adoption, basically. You measure some process and stuff. Does it change after you introduce this thing compared to status quo? Okay? The process change or not? Do they take longer and so on and so forth? Are people taking the full implementation or not? Something like that. Here's different. You have both an effectiveness, it's the main focus too, but your secondary focus is really comparing 2 intervention strategies, meaning I have 2 ways of delivering that intervention or 3 ways, and I'm evaluating not only if the intervention is effective, but how do I deliver it? And the example of mindfulness, it was done before. I would say 1 hour session covers everything. The other intervention would be 1 hour plus followed by another hour session plus 2 follow-up sessions of reinforcement over 2 months plus a video. The other one is a variation of that. So I have 3 implementations to see which one has the greatest impact on the effect. You see that? That's a hybrid type 2. Okay? What makes for a test of an intervention here is that at least one outcome measure is being used and that at least one related hypothesis, however preliminary, is being studied. So it's still an effectiveness trial because you're still combining the evaluation of the intervention delivery with an evaluation of the effectiveness of the intervention itself. So you can read this. I started at 9:30, right, Fred? So I only have 10 more minutes. Is that right? It's about 10:20, right? So let's move quickly. So there should be implementation momentum with the clinical system or the literature toward routine adoption of the clinical intervention question. So, read this. We need to move on. I'll go to the example. Here we want to evaluate effectiveness relative to the usual care of a chronic illness care model. So the chronic care model that we call chronic disease care model, okay, on clinical outcomes. This is, by the way, is developed by people in University of Washington, Seattle. Okay, I met with that gentleman who created that system that's being adopted by many clinics in the U.S. for the past 30 years. So they want to evaluate the chronic illness care model as a delivery method. It's a major strategy for controlling and diminishing the burden of chronic disease in chronic disease patients. It's a lot to do with self-care. Self-care came from here, okay? But it's focused here. This one is specific focus on clinical outcomes among persons with schizophrenia. So there is a controlled trial of implementation strategy, okay, to facilitate adoption and sustain chronic care model. But you're still interested in the main outcome of it. In this case, maybe a chronic disease that gets worse or not among schizophrenic patients. I'm just guessing. Let me see. Controlled trial in 4 veterans integrated service network. That means 4 VA hospital system. And each of these integrated service network, one medical center assigned to clinical intervention and supporting implementation strategy, and one to the usual care. So each of the 4 has 2 clinics. One is taking up the new chronic care model. The other one is taking the usual care. So it's 2 multiplied by 4. So you have eight centers for one implementation, 4 with another implementation structure. But still the same outcome and the same interventions, like from the point of view of medication or adjunct treatment. So we're looking at real implementation here. We're beginning to really look at implementation. It's a controlled trial in each medical center assigned, like I said, FE used to understand and continue to adapt implementation of the clinical intervention and implementation strategy. So I should have said what the heck FE is. I forgot. FE. Goodness. I'm sorry, folks. I'll remember later on. I should be careful with those terminologies, being on many years since I pulled this one off. But anyhow, you can see that the focus here is in both. The clinical outcome, the intervention, whatever is the treatments being given, that's not changed. What is changing is the controlled trial of the implementation strategy. In one group, there's marketing, education, facilitation, product champion intervention to facilitate adoption and sustain chronic illness care model. So not only they adopting a chronic care model, but they have all these supporting activities going on, okay? And they want to see if the effect on the implementation is better, and if the effectiveness change also. It doesn't say here, but you also look at the effectiveness level that you obtain for the outcome of interest. The hybrid design type 3 is testing an implementation strategy. It's very similar to that one, okay? Secondarily, it's observing guided information on the clinical intervention impact on relevant outcomes. Okay, so the focus here is on the implementation. Involves situations where health system actually encourage or attempt implementation of a clinical intervention without the desired clinical effectiveness database. Could include the presence of respective consensus guideline. There was no real study of effectiveness before, but there's a consensus guideline, strong indirect efficacy or effectiveness data from literature, maybe from observation design, advocacy from patient groups, providers, or lawmakers pushing that intervention, and administrators seeking to reduce costs by implementing a cheaper clinical alternative. Usually it's a combination of those. So at least you like to evaluate the implementation, if it's being implemented optimally, if it's being implemented with some minimal level of fidelity. In this case, it is therefore important to proactively include resources to collect evidence of clinical effectiveness, because you're also going to look at potential outcomes out there and as a population as a whole. So you're looking at the grouping of the information. So I'll give an example. You can read this over because we are running out of time. The example here is to evaluate selected clinical outcomes after implementation of model of integrated primary care and mental health. Okay, so randomized test of an implementation strategy. So the intervention is the same, no change. It's like type 2, but really the focus here is on the implementation. Facilitation for internal and external experts using multiple implementation interventions to support adoption of 3 models of integrated primary care and mental health in comparison with a nationally supported dissemination implementation strategy. So there's a paper here I want you to read, and that's a much large scale implementation, lots of measurement on the implementation. There's something else I want to bring to your attention. I'll cover that later very quickly. Okay, not the next hour. And then, so we're going to stop here and we're going to cover in the next 2 hours with 55 minutes to an hour and then a break of 50 minutes, another 1 hour. We're going to cover examples of effectiveness, evaluation of effectiveness of public health intervention. All of those are examples. I was involved. They're not perfect design. That means I was courageous enough to make mistake, have reviewers from journals killing me, complaining about the mistakes made, and then getting the evaluation done. And 3 of those were done in Brazil. I have more in Brazil, but these are 3 of them done in Brazil, okay? If if I can run quickly on, then I can even show you an example of a meta-analysis, that two meta-analyses we've done on diabetes intervention. So a 10, 15 minutes maximum break. Okay, folks? Thank you. break and show more examples of evaluation. And I brought examples from here that I help many of your colleagues here, some in UniFasp actually, to evaluate a medical or a public health program. So before we present the example, I'm going to just give an overview. We're supposed to cover that when we did the trial, but we ran out of time on clinically randomized design, control design, as well as when we talked about cluster randomized design that you are cover, or step wedge. So there's something else called pragmatic trial, and that's not new. It's from 1967. People already worry about that. In 1997, sorry for the typo here, others were also worried about that. But the key question, I still think this guy in 1967 was right on the money on this issue. So he's saying the typical studies we are stimulating people to do, it's what I call, Schwartz called explanatory trial, causal relationship type of research, trying to test a hypothesis about the biological, chemical process, something. So that's a really experiment. That's explanatory trial. Even the observational design is say what caused lung cancer and so on and so forth. It's an exploratory type of study. Whereas he was worried about something else. Say, well, can they answer the question about decision-making in clinical care? What sort of care do I need? Trials should be designed to answer a question about clinical care, not about a relationship between a drug and an efficacy type of thing only. He was already hitting on the issue of effectiveness, real world, on the issue of implementation, on the issue of dissemination. So in 1997, this other researcher say, could this intervention possibly work in the real world in uncontrolled conditions? And I gave you an example early on about the use of Viagra that people didn't expect to use the way they use it. And people having so-called, not considered to be a side effect of the drug. It was like an unexpected event related to the drug. Okay, so that's a real world condition. Could this intervention possibly work in ideal control conditions too? So it's both questions are genuine, but the first one needs to be answered. So we're talking about pragmatic trials. That's what you're promoting. You can slightly modify the existing clinical randomized control trial or a cluster randomized trial, which is very controlled by the scientist, the researcher, or even a stepwise randomized cluster randomized trial, and do what we call a pragmatic trial. So I think the corollary of pragmatic versus true exploratory trials is the internal validity. Okay, you remember the issue of internal and external validity. Internal validity is basically saying, is it doing what it's supposed to do based on the perfect science and the perfect nature of these relationships? Is it being expressed as it should, this relationship? Whereas external validity is different. It's say, once I found this relationship, can I extrapolate what I found here for other settings, other scenarios, other types of people? Okay, so this externality is involved in how you ask the question about relationship, about causal relationship. Okay, well, internal validity is improved tremendously by the randomized design because you eliminate a major flaw of internal validity, which is confounding. When you do a study that you did not take care of confounding, epidemiological study that is, or any other evaluation of intervention or effectiveness study, you are not in a valid territory. You are maybe an invalid territory. You need to take care of potential confounding, okay? And I already explained, and there's a whole lecture. Wanted to review that lecture. I think it's the best lecture I ever put on the whole training here, is that one on error. Error from epidemiological error, what's called systematic error that invalidates what you're finding, or random error, statistical error. And random errors is not too difficult to control. You just add sample size and do the right stat for the right hypothesis. There's no error. But systematic error, if you make it, it's going to carry over the whole study, and there's nothing you can do about it. You can only maybe a posteriori estimate, oh, I incur in that kind of selection bias or information bias or misclassification or confounding, and therefore this is affecting my result. So it really is about internal and external validity. However, the most perfect the randomized trial is, the best efficacy trials you can get, the worst it is to replicate that finding in the real world. because perfectly randomized control trial lacks externalities. Externality is what makes things adoptable. You control everything. Let's say a perfect clinical trial for a new medical strategy. Like I use this example over and over of aggressive. That happened actually in the 70s and 80s, or 70s or 80s. Aggressive monitoring glucose and initiation of insulin on very advanced diabetes patients, type 2, decompensated, and type 1 patient. So if you have an intervention like that and you do a perfectly randomized control trial, that's what they did. So what that means that everybody, the team of research and the team of people delivering the intervention, they're all trained to do the right thing. Everybody was built like that, meaning they are committed to do the right thing. They are trained and they had incentives to do right. Many of the health people in the field receive additional funds. The system received funds from the researcher, and that's normal. So people are doing the right thing. The patients are all compliant because these are more severe patients. They usually tend to be more compliant. It's very rare. Usually non-compliant patients are patients that have mild cases of the condition. If you have a severe case, people finally are afraid of death, right? So they start doing the right thing. So you have a lot of perfect scenarios here. Now come to the real world. I give it again. So this diabetes monitoring, let's say they found out the ideal monitor would be 7 times a day. How feasible is that in the real world, not in a clinic? You see what I'm talking about? How feasible is for the patient to be measuring themselves? Back then, the monitors you have today are very easy. They don't hurt. Back then, they would hurt you. Okay? And you have to take your blood 7, 8, 10 times. Is that feasible? So that's a real world. So that efficacy that you found there, you'll be much less efficacious in practice, be less effective. And then you say, now I'm going to distribute that to a whole population. The insurance A is going to pay, but the insurance B is not. So some people will have money to do the intervention for 3 months, and then a month later, they are still back to the old type. So bottom line is real world is different, right? And that's what I'm talking about here. So pragmatic trials trying to imitate real world while doing a decently designed study to find the truth. That's my best explanation of that. So I put down here a summarization of Thorpe in 2009. The traditional exploratory trial be narrow eligibility. I create such an eligibility criteria, only include people who can really help me discern whether the intervention has an effect or not. I eliminate a lot of people, potential confounding variable, people who have conditions that may affect a comorbidity that's hidden, it's hard to find, whatever it is, study. So narrow eligibility, pragmatic trial, broader. I accept all kinds of patients. Flexible intervention for the pragmatic, strict instruction how to intervene, everything is controlled. Typical practitioners are used on the pragmatic. The expert practitioner, I'm dealing with only endocrinologists, whereas in a pragmatic, I'm doing the primary care where most of the patients are. Okay? No follow-up visits. The other one has frequent follow-up visits to make sure that the patients are compliant, that people are delivering the right drug at the right time, they're doing the metrics, the measurement all the time perfectly. Objective clinical outcome, that's what I'm looking at. Here in the narrow, I use surrogate outcomes also, in addition to objective. I forgot to add the objective outcomes are here too. Usual compliance and a pragmatic close monitoring. That's what we're doing here. This one here is either intention to treat plus per protocol. Protocol had a definition, how we're going to treat patients of such and such type, whereas the other one would have only intention to treat. So in doing so, some people, folks from Thorpe and the other group developed the pragmatoscope. You can see it here, read over quickly. So what does it mean in real world? Read over, I want to show an example of the difference between them. That's more on the same topic. You can read over it. This is an example of a randomized trial. The word control, it's a control, but it's not quite control. What we've done here is published in Journal of Physical Activity Health. And to test a promotion of leisure time physical activity among older people. So in that evaluation, we knew that participants were randomized in 3 groups. the control called MIG, minimum intervention group, the PCG, physician-based counseling, and the individual counseling and referral for physical activity program. So these are the two interventions you're looking and comparing to each other and to the control. Subject are recruited from ongoing cohort, so therefore there's an existing cohort, we recruit them from there. More likely to enroll. The eligibility criteria is very loose. A lot of people participate. So it's really, even though we wrote control, it was not really a control trial. The journal let us go by. Dr. Rome is very convincing. I think it was the first author. No, it was another researcher here. It was the first author. And the journal didn't say a thing, but it was not really a control trial. Study setting similar to setting of elderly patient in the community who use the Center for Study on Aging that used to be here. Still is theoretically, but it's very diminished because it was a center created for existing cohorts. So the setting is not a clinic, perfectly controlled environment. It's really a primary care clinic for older people who people come voluntarily. There's no set schedule. They'll come and schedule, really close in time to participate. So intervention was delivered, resources, provide expertise in organizational care, similar across, we guaranteed at least resource, provide expertise in organization of the care was similar for intervention arm because they're all delivered through the CSA. Flexibility of the intervention was very flexible delivery. So it was not a rigid, totally controlled setting. The delivery was not always the same time. It would vary because it's delivered by primary care doctors. Dr. Roma was involved. Sometimes you have, students helping to deliver the intervention to these folks. So there was no same person, same instrument, same video, same material all the time. No, it was a little bit loose. Subject monitoring, encouragement to adherence to intervention similar across. We thought the monitoring and encouragement was similar across the three arms, the CBG, the PCG, CRG, and MIG. Okay, so this is what we end up with. Here you have a major finding already, just in a simple table like that. You have the two interventions, CRG, PCG, okay, and you have the MIG, okay, and then you have cohort baseline. That's a baseline. At baseline, they're kind of similar. You can see 69.7 not active for CRG, 68% for PCG, and 69% for MIG. So they're very similar. As you go from cohort baseline to pre-intervention, post-intervention 1, and another measurement, we did 4 measurements. I convinced folks here to do more measurement, okay? So you can see that the not active changed substantially. It becomes 39% on a CRG intervention group, 68% on a PCG, and 77% on the control group. So that means all the groups improved. The number of non-active diminished. But the one that really improved substantially was the CRG and the PCG relative to the control group, okay? So that was an intervention that actually worked, but it is a pragmatic trial. There's chance for selection bias. There's chance for confounding. There's a lot of flexibility, like I described, and a lot of things we implemented, and that could have contributed to those differences. But I don't think that's another thing you learn from practice. When you have strong effect, this is a strong effect. If you calculate the risk here, it's going to be pretty high, a difference in risk. The highly active is 33.3% in one group, 16% in the other one, is 7.1. So the ratio of these two, 33.3 by 7.1, is nearly 2. So the people who were in the CRG group are twice more likely to be active after months of intervention than the control group, okay? So that's a powerful effect. So when the effect is very large, you cannot attribute that easily to selection bias or confounding. Could be, still, but it's still a randomized trial. We randomized the groups, but so confounding was more or less controlled, but the intervention was not delivered too much flexibility. And there's a chance for introducing biases by those who are delivering the intervention, those who are receiving the intervention. The settings, a lot of possibility of what we call information bias or misclassification of the exposure, okay? So that's part of the situation here. So, but I want you to read this. This was done here, Okay, that's another way to show the effect. You can see the effect here, the CRG line, the PCG, and the MIG line. Okay, the MIG line is the one that's 81.3 at post-intervention 2. The other one is 112. The other one is 2021. Now I'm looking at different outcome. Before I show the proportions, I could estimate the relative risk, which we did. But here I'm showing the amount of time people are spending, average minutes per week of physical activity, leisure time physical activity. So the one group went from 128 to 221. The other group went from 114 to 112, more or less. That didn't increase much. Went up and then went down a little bit. And the other one, the control group, was 109 and 110, more or less, and went down to 81.3. It got worse, the number of hours. The number of people exercise improved, but the number of hours they spend on minutes exercise got even worse for the control group. So many ways of looking to that. This way, that's a relative risk measure, okay? The proportion here in the CRG group, okay, which is highly active, is 33% divided by the highly active 7.1% in the other group, okay? So that's nearly a twofold increase in total, in general, being physically active or not, at least 3 or 4 times a week. And here's the number of minutes that we actually were able to estimate the number of minutes. It also went up substantially. It kind of plateaued a little bit and go down a tiny bit, but still very high for one of the interventions. The other one that I show effect also here, the PCG, but the total minutes was not that good, okay? But that's a true evaluation done here in São Paulo, here in Villa Clementino. So if I can do that, you can do that too. Hang in there. I'm going to look for another example here. Is that from my drive? Yes. Okay. So let's look at more example before we close. Yesterday, I showed to you an example of a randomized trial evaluation. Now I'm going to show you a cluster randomized trial. So you can contrast that. Oh, that's not it. That's going to be the last one. It's very long. Goodness. That's not my stuff. Is it?
Yes, it is.
Jesus Christ. I'm not finding what I want to find. Okay, I'll go here again. So yesterday we showed this example here, okay? And then I stopped halfway through because there's another example, which is from a cluster randomized design. We went over this in detail yesterday. Okay, now I'll give you a little bit of real example. You remember all of that. I'm not going to take much time on this first slide, but remind you that in a cluster design, you have 2 levels of variance, and the way to estimate that effect on the variance and your sample size is the design effect, which is 1 plus rho multiply m minus 1. And rho is the intraclass correlation coefficient, which is the proportion of between variance divided by the summation of between and within variance. Okay, and m is your total number of participants, which is kn, is the number of clusters multiplied by people per each cluster. That's your m. Okay, so here we're good. We show an example of a cluster randomized design in which the unit of randomization is the cluster. Whatever is the cluster defined, in this case, is going to be clinic, and the unit of analysis is the patients. We still want to chase an effectiveness trial, understanding the effectiveness of an intervention. So we're going to compare standard model of antenatal care, this is like babies, with a new model that emphasizes actions known to be effective and improve maternal and neonatal outcomes and has fewer clinic visits associated with that. So we're going to test if that is true. Stratified cluster randomized design, and that's another variation of the cluster randomized design. I cluster randomized within the strata, and the strata are based on the countries and clinic characteristics. So in that way, I'm adjusting already. I'm matching. When I do a clustering within the strata, every cluster in that strata has the same strata effect. So there's no difference between them, okay? Everybody's in the same strata. And that's the whole thing. So you control it for confounding, so to speak. Unity of randomization is clinics, 463 women recruited by clinic on average. So there are many clinics, on average about 463. If I divide all the participants, study participants, by the number of clinics, that's 463 women recruited. The hypothesis, the new ANC model, antenatal care model, based on components shown to improve maternal, perinatal, and neonatal outcome, is as effective as the standard ANC model with regard to low birth weight and maternal morbidity. So they have two specific endpoints, two specific dysphasias or outcomes. Okay, the same, they mean the same, low birth weight and maternal morbidity. And it's not more expensive and acceptable by women and providers. So it's a little bit, it's like hybrid one. Remember hybrid one, you have a randomized trial, your effective trial, but you still measure cost and acceptability. So that's a hybrid one. You get a little bit of that. So here's your design. The antenatal care trial study design flow chart. 24,678 women are enrolled in 53 ANC clinic, antenatal care clinic. I eliminate the not pregnant. I only look at pregnant women because I'm looking for what? What's my outcome? Low birth weight and maternal morbidity, right? So they need to be pregnant. Sorry. So now I allocate them, randomize them, the clinic, not the patient, the clinics. I allocate new ANC model clinics. 27 of the clinics allocated to the new model, 26 to the old model. You're trying to balance the allocation always. Because it's an odd number, you cannot really have exactly the same number, but you're trying to do that. And that helps with the statistic. I'm not going to get into that. It helps with your hypothesis testing and your variance estimation. So you end up with some loss to follow up in both groups, 2% in one group, 2.4 in the other one. You also have abortions, which cannot be, it's already aborted. So it's about similar across groups too. And the birth. So that's your main outcome as the birth. I mean, your outcome is going to be measured after the birth. So you have 93.7%, 93.6%, very similar proportion of birth in both groups. So the randomization looks like worked well in the clinics, across the clinics. So you have 11,672 single birth on this clinic and 11,121 single birth on this clinic, on this group of clinic, the clusters. So clinic characteristics, location, new patient resources, enrolled women, demographic, obstetric, gynecologic history, present pregnancy status, gestational age at entry to the trial. So the gestational age was 16.5 for the new ANC model and 16 for the standard ANC. So gestational age. This is how many, what do you call it? How many months you have? Weeks, sorry. The antenatal care trial baseline shows that who was the principal provider of ANC. We have a little difference here, so you need to adjust for that because 61% in the new model clinics and 57% in the other one. Small difference, but nonetheless is a difference. The other one, general practitioner, is more or less the same. I mean, so they're kind of comparable, not quite for the top one, the gynecologist. You have a better, on a new model clinic, the one they are allocated to the new model, have a slightly better number of obstetric gynecologists. So maybe that would influence the result. So here are your results. You have clinics in Argentina, Cuba, Saudi Arabia, and Thailand. The new care values are here on green and the control in the white. This is antenatal care trial, number of visits. This is how many visits the patients had on average to the clinic. You know that ANC, a new model, is going to be more intensive collaboration with patients, trying to get them to come more often to the clinic, right? So that's why you have the difference between the two groups in terms of routine delivery care. But in this case, it's actually the control is being a little bit more visits. Probably, I'm just guessing, because they have more issues, more health issues. We don't know, but it's showing a difference, a slight difference. Sometimes the confidence interval cover each other, so it's not real difference statistic, but it's an effect, a difference. The antenatal care clinic primary outcomes. This is your primary outcome. That's what you're interested in. Okay, you have low birth weight, eclampsia, postpartum anemia, treated urinary tract infection. So the low birth weight is one of your main interests. Remember, the other one on the trial was, I'm trying to remember here, maternal morbidity. Oh, it's very general. So it does include all three. Morbidity is any disease that happened during the process of maternity, especially close to the time you have your baby. So out of these women, you see the percentage here, okay, for the new clinic and standard clinic. And on the side, you see the column is estimating a risk odds ratio, in this case, a risk odds ratio. They did an analysis through odds ratio. Probably use logistic regression. This is a IDAC proof. So effect was heterogeneous across sites and strata. Therefore, pool estimate may hide site-specific effect. So the star here is saying, the effect is pretty much about the same. But look at the confidence intervals. This one is missing 102, but I want to believe it also includes no hypothesis. All of them include the no hypothesis. So on this first look on the odds ratio between the two groups, the new ANC versus the standard ANC, there's no difference between the clinics statistically, so to speak. And you can see by the percentages, okay? The percentage of women with low birth weight in the new clinic is 7.68, and the standard clinic is 7.14. It's very small, minute difference that provides an odds ratio of 1.10, as close to 1 as possible. So you have no effect. That's why the confidence interval include the no hypothesis of odds ratio equal to 1. Okay? So all of them. So there's no effect of the clinic. The antenatal care trial primary outcomes, I already showed to you, but there's another way. I'm going to look into that in a bar to show these confidence interval with a bar graph for the different diseases. And you can see the new NC versus study. Even though it's not significant, it looks like there's a little bit of effect for anemia and treated UTI, but not significant. And then we go on to, again, to show the percentage and a more structured way, pregnancy-induced hypertension. I'm looking to a lot of other things. And there are some difference, but pretty much the same. Not big difference, right? Anywhere except for pregnancy-induced hypertension. It looks like a little bit higher than one group than the other, but altogether is about the same. So the new ANC model is as effective as the standard model. So if I'm doing, remember that? How many clinical trials I can do, how many hypotheses I can test it? Inferiority, superiority, and equivalence. If this is an equivalence trial, I don't know how they set up their hypothesis. At least to prove the ANC, it's not worse. It's about the same, not worse. That's an inferiority trial. Okay, so bottom line is this is an example of a cluster design that you cluster patients into clinic and you randomly select cluster. You look at factors. This is a good example. Which factors to look at to adjust? So in their modeling of the odds ratio, they probably use logistic regression and risk odds ratios, not exposure odds ratio. This is not a case control. This is a real trial. They have a cohort. They know that the intervention precedes the outcome. Okay, that's a risk odds ratio, which is an indirect measure of the relative risk. Okay, that's another example I wanted to show it to you. Let me see the other one. The other example I want to show it to you is this one. So how is my time here, Fred?
It's 11:15.
Okay, how many minutes I already have presenting this pragmatic trial thing?
1 hour and a half.
Already? You need to stop now, right?
Uh,
Are we being 1 hour?
You have still 1 hour.
No, but I'm lost. I started at 9:30, finished at 10:30, right? And then took a break 15 minutes. We started at 10:45. So what time is it now?
It's 11:15.
10:45. So we have done 30 minutes. This is too big for 30 minutes. So let me see the other example then. Give me a second, folks. I think we need to stop presenting that. If it goes over, we're finished on the other part, and then I'll show a little bit of meta-analysis. It's better that we start here. So this is another example of evaluation that I wanted to present to you out there. This is the program I mentioned to you. This is a physical activity program started 30 years ago in the city of Recife that stayed there in different titles and names. It changed name 3 times. And that's why later on, 30 years later, I could not recognize it was the same program we have initiated in Recife way back. But they have added elements to it, very important elements. So just to give a story of the Academia da Cidade do Recife, originally was a program by a Secretariat of Social whatever. I forgot what the name was that. The secretary is Montenegro, Dr. Montenegro. He was actually a lawyer. So that program consisted at that point in time of a free for all physical activity what do you call it? What did I write the word for that? It's a physical activity session oriented by a trained and graduated from a 4-year college physical activity teacher who is trained in recreation, leisure time, activity, light and moderate activity. And they have to develop a little program offered free to the population in specific sites in the city 30 some years ago. And the sites were modified to receive people that will go freely, don't pay a thing. And they will take their blood pressure and they'll make sure that they didn't have any major thing. But it was very free, very loose. And the physical activity teacher will hire and started in 4 sites in Recife. Those 4 sites continue as of today. But over the years, this intervention changed from the original name, Viver em Saúde, it's like living and health, to Academia da Cidade. What did they do in the process? About 15 years ago, 10 to 15 years ago, the Secretary of Health of Recife adopted the program, say this should not be a Secretaria de Ação Social or social action. It should be a health program, which was the original intention, but nobody wanted back then 30 years ago. So it went to Secretaria Social, who adopted. So now they brought to the Secretary of Health major change. They make the physical activity teacher and teacher or educator agent, a health agent. They create a classification for them, give them a budget and a salary. The others were contracted by Secretaria de Ação Social before. They connect the program to a healthcare system belonging to the municipality, meaning the people who are participating in that have preference or priority in trying to get primary care clinic. They added nutritionists placed there and better training on how to react to somebody has a heart attack or something, mouth to mouth, whatever was needed. Plus, they added the material and equipment, more structure, and create a little house where the equipment were stored. So these are innovation, but their program is essentially the same, exactly the same as before. The program before, like I said, was a free for all physical activity intervention by a physical education teacher trained in recreation and physical activity. That did not change. And offering these activities free of charge, starting at 6 in the morning all the way to 8 in the morning, and then from 4:30 in the afternoon all the way to 8 o'clock at night or 7:30 or something like that. Okay, that was the same. They adopt the same schedule, the same places, the same idea of the physical education teacher, the same type of activity. So they have to create a little curriculum of light, usually including aerobic and calisthenic combination. So it's still the same. They may add some music, some dance, but it's still essentially the same. But they added all these structural things. It made the program much more structured. The re-engineering was done better. They really modified the space. So that's the intervention. So this intervention was evaluated early on by us, meaning the group of universities in U.S. combined in partnership with Federal University of Rio Grande do Sul, Unifesp, Dr. Ramos, and Catholic University in Curitiba. So these 3 initial partners in Brazil, plus 2 universities in the U.S., St. Louis University and San Diego University, partner to offer evaluation. So we done an evaluation of Academia da Cidade do Recife, the new program. Okay. Here I'm presenting something else. A few years later, 3 or 4 years later, the state of Pernambuco decided to expand the Academia da Cidade do Recife to the whole state with slight modification, but it's the same idea. So they had 164 cities. So we look into that, say, hey, there's an opportunity. So we contact the State Department of Education, who was doing that actually, and planning and education, and say, and health, they're combining there to do it, and say, can we help you to evaluate? That's the evaluation. Okay. So the Academia da Cidade de Pernambuco now, instead of Academia da Cidade, so Academia de Pernambuco. So it's no longer, there was something, Academia C, I don't know what the C stands for. What is it? Have I put the name? No, I did not. They are calling PACID, Pernambuco Academia da Cidade, whatever. So it's being expanded to cities, offer opportunity to augment evidence-based recommendations for this practice. The IMIP, which is an Institute of Health linked to a university, IMIP is a university now. Back then, I didn't think it was, had conducted an availability study that we asked them to do it after the government of Pernambuco accepted to be evaluated. And they gave me critical information about structure of the program and the readiness of the local politicians to implement the program, logistics, and so on and so forth. So here's the state, and 185 cities will receive the intervention over. They expected to be in 2 years, but in reality, I knew it was going to be longer. So I say, we have time to do this. Let's implement little by little. Okay. So the objectives were evaluate the impact on levels of physical activity in each of those cities where the program is being expanded. Evaluate sustainability and cost effectiveness of the program using a logic model to identify inputs, process, and outputs. A little bit of implementation science here. You see that? Build a community participatory approach that empowers community and enhance governance of municipalities receiving the PACID resources. Well, that was already part of the intervention. So we enter the evaluation also as part of that participatory process. Disseminate result of the evaluation project. So there's a theoretical model, more or less, where we based the idea of the mixed evaluation. So we basically had, during the time in July 2011 through July 14, there will be municipalities in different stages of implementation. That's my rationale. I designed that study and brought a team of people to do it with me. And we obtained funds from a CNPq. I'm going to show the number later on. If you go to the publication, what I'm going to show at the end, you're going to see the CNPq research grant number supported the scientists and Rio Grande do Sul, everybody to do this. So we hypothesized that cities without the physical change, you'll be a reality, because that's the status quo. And there will be cities with re-engineering space only after a few months, but not activity yet. City with space and already initiated some classes and professional were hired and contracted. And city with space, LTPA classes, leisure time physical activity class, professional hire contract, trained professionals, and also some other communities will have a combination of the G1 group, or X1 is the intervention, G1 is the grouping, the clusters of cities, through G5. That means they have everything, and they have early and delayed start. Some will start early, some will start later. So I knew all these combinations were possible. So I'm not designing the intervention delivery. I have to rely, but I'm observing. And guess what? The intervention delivery goes more or less like that. Okay? This is very similar to that. Remember the step wedge design that I gave it to you? Everybody starts at zero at the beginning. See the zero here? And over time, little by little, everybody's getting the intervention. And those sub numbers indicate something different. You can read that later on the evaluation. So even though it's a natural experiment, it's a quasi-experiment in a natural experiment. Why? Why is a natural experiment? I'm not the one delivering the intervention. The state of Pernambuco is. And they are against delivering, because I asked them, can you randomize the intervention? Can do a step wedge randomized? They didn't want it. Just the word randomization got them scared. I should have been smarter and presented this in a better way, but they didn't accept. So is that really, am I doing this? Yeah, in reality you are. Not really through randomization in your life. Consider this. There will be municipalities that when they see the announcement of the grant, they immediately apply for it. They have all the structure and they'll obtain the money immediately. And they'll start implementing immediately. Some of the other municipalities will take longer to apply. By the way, they said it's going to be delivered in 3 years. It was 5 actually. But that means they don't have money to do everything in 1 year. So it's a first come, first serve, right? So bottom line is not everybody's going to get the intervention at the same time. So little by little, they're getting the intervention. It's like this, it's like this. But it's not a randomized in that way. It's non-randomized, the reality. And we measure that afterward, and it does show a little bit of that. It's very similar. So it's almost like the ability of a county or city to obtain the grant, to implement the program, to train the people, vary across. And some started in the very first year. Some will only apply on the 3rd year. So always had some people are controlled until the very end. So it's like this. See what I'm seeing here? The light blue here, that's a control group. I always had, for each sequence here, I had many clusters of city in this case. Each city is a cluster. And the patients are clustered, the individuals on that community are clustered in that city. Okay? So I treated as a stepwise design. I treated that also analytically. So you end up with any possible comparison, group 1, group 2. These are the clusters, okay? And survey 1, so I did cross-sectional surveys of those counties, the cities and received 185 cities. Okay? So the intervention may affect or factorial design. We didn't do a factorial design because of the way the intervention was rolled over. It's little by little, it mimicked this. So we're talking about main effect with only one intervention in several layers compared to a control group. And the layers are defined over time. Okay? Schedule for data collection. So we decided to do a natural history of the intervention group at city level and sample groups over time to create various kind of a comparator design. 2 or more baselines will produce a pre and post. Additional follow-up intervals will allow me to see a little bit more than pre and post. Look at as either a post-test only control group design or pre-pro test. So we did a pre-test, post-test control group design, but the controls are doing naturally. It's a naturally occurring control. And instead of just having one pre-test, we have a pre, a mid, and a post cross-sectional survey. Okay? So is that a cohort or cross-sectional stepwise quasi-experiment? In nature, I didn't do it. I designed it, taking advantage of the intervention, being rolled over as a step wedge. So it's a nested cluster cross-sectional design because each city is a cluster and I'm sampling their residents across all the 105. Every city is a cluster, so I randomly sample the cities. Right? I was saying how this is done. I have 185 cities, so I take a random sample of 50 cities, okay? And out of the 50 cities, I take a random sample of their patients. You follow that? So it's a 2-stage sampling, 2-stage random sample. By the way, it creates a larger variance because I have variance between clusters and I have variance within cluster, okay? So a priori match or stratification can be implemented with sample units selected randomly from previously stratified groups based on a factor that affect both intervention, status, and outcome. Matching may be a possibility. I didn't do neither. But during the analysis, I did a partial stratification based on the size of the public health department or the size of the cities. I adjust for that, okay? So units of assignment are city group, and then the allocation of condition, it was PASI, the intervention of the quasi-experiment type of group historic assigned to condition treatment, units of observation, members within the city. So the cities and the intervention are interacted. So it's the intervention developed to the city. This is not an intervention that was delivered to X number of people in the city. They are offered to the city because the city is very small in Pernambuco, except for 3 or 4 of those cities. then one intervention means everybody might have access to it. You're talking about a city of 5,000 people. How many adults you have there? Think about it. How many are children? About 50%, right? How many are active adults who can exercise between 5 and 8 o'clock or 6 to 8 o'clock in the morning? About 20, 30%. So we're talking about maybe out of 5,000 people, about 1,000 to 1,500 people. And then they have the academy open every day of the week, 2 times a week, so they can do in the morning or in the afternoon. So you could cover quite a bit of people. In Pernambuco, in Recife, when we measured this, the academia was doing in 13 sites that they were doing an average of 10,000 people monthly. Okay, so it's pretty much spread. There are some assumptions made here. So note that groups selected within one survey wave are independent from the other group. Group meaning the cities they are selected. Just read about it. Overall, we basically had randomly sampled the cities, and within the randomly sampled cities, we randomly sampled their population for a number that has the right power to estimate the effect. Okay, and what effect is that we expect? We had a prior evaluation, which is another observational design, not a quasi-experiment. I done a case control kind of on Recife to evaluate the Academia da Cidade there. Here's the expansion to the state. And it shows incredible effect, but there are so many possible bias in that study that I needed to do a more closer to a real randomized trial. It's not randomized, but it's as close as we can get. Okay, so the outcome is leisure time physical activity, or it could have been transport physical activity or total physical activity score. We had both in all three. Measured by IPAC, are you familiar with that? International Physical Activity Questionnaire. Long and actigraphs. We have both. Actigraphs is equipment that people carry to validate that. At that point, I had designed a study to validate the IPAC in Brazil. So I did a study in Rio Grande do Sul to validate how valid is the estimation coming from IPAC. And it was shown to be very valid to classify people in active and inactive, very active, inactive, moderate active, inactive. Not good to tell how many minutes or how many mats of exercise you exercise. No good. I proved that was not. But it will easily classify people into group, and that's what we needed for this study in epidemiology. And that's why we use that. Conditional intervention, as you know, is PACID yes or no, or PACID at different stage. Does X1, X2, it just indicate a classification, a typology of implementation. X1 is like, I only got the money on the program. X5 means I got the money. I modify, engineer a place, a physical place where people can congregate and do those activities. Open, it's in the open. I train, I hire faculty, physical activity, not faculty, teachers. I train them, and the people already exercise, and I connect them with the Secretary of Health, giving maybe priority for these people who participate to have priority coming to a line for primary care attention. So that's X5. So I create a categorization of the implementation. That's an implementation kind of size, but it helps you because you have an expectation that the effect of the intervention will be bigger in those who are X5 than X1, and much bigger in X5 than those who have nothing. Okay, X1 is like some level of intervention. So factors associated with PA scores also measure, so I could adjust for it during the analysis. Okay, including SES, city size, city revenue, how much money they generate in the city government, because those things are associated with structuring and organization of a municipality and the ability to deliver a new intervention. If it's a very poor city, let's say, Recife, Igaraçu in the north of Recife, it's a small little city that's very poor, and they don't have enough money. I bet their intervention is going to be very poor too. It reflects the lack of organization, lack of money. Okay, so we need to adjust for all of that, because therefore you're assuming that everything is homogeneous, the intervention is perfect, same intervention in every city. It's not. So those things adjust for the effect of this misclassification of the intervention. Study effect of PACID, two sources of variance: the group, the city, and it's a cluster design. So that's the setting. We also did a few sub-studies, like I said, the accelerometer, to prove it again that the people who said, yes, I'm active, the accelerometer is proving it. Are you familiar with accelerometer? Are you familiar with that accelerometer? No, you've read? It's an equipment you put over here electronically. It put in your hips, on your seat belt, or in your pocket, and it measure during the day how much physical activity you have. But it's electronic. It's very precise. It's not those little monitors that you put, which is mechanic. This is electronic and measure impedance, electric movement. SOPARC, we also use SOPARC to validate. It's a it's an innovation I had from University of California at San Diego that allows it to validate people are actually in the place doing activity and so on. There are all the qualitative stuff we've done. So is it time now? Is it time?
11:30.
Yeah, we're going to stop for 10 minutes. Yeah, we're going to stop for 10 minutes, not 15. And then we'll continue until about 12:15, 12:20. Okay? We'll finish that. That's an interesting analysis. I want you to see it, that taking advantage of something's going on to do a quasi experiment. So that's an important piece. 10 minutes, folks. So welcome back, everybody. We're going to continue this evaluation. Like I said, it's a very interesting study because it demonstrates to you a very large scale quasi-experiment that takes advantage of the implementation and the characteristics of the implementation to envision ahead of time that this is going to be rolled over as a step wedge design, even though it was not designed as a step wedge and it's not randomized. And the reason, I remind you again, why the rollover of the intervention over time becomes a kind of a stepwise design with that characteristic is because many municipalities would not be able to implement the program as it's supposed to be initially. You take time for them to develop. Some others will come earlier and deliver everything. Some others will come very late to deliver everything. And some others may have other issues to deliver. Therefore, you're always going to have at the end a very large number of municipalities without the intervention. Some others with decent degree of intervention, but not too much. Some others with a lot of quality of intervention already implemented, and some others with lots of good quality of intervention. Every aspect of the intervention is in place and for a longer period of time, for 3 years. So you would expect for those who have longer effect and more structural and more comprehensive intervention implemented for a long time to have the highest effect. And that was what happened, actually. Okay? So in the evaluation of PACID, the sample selection logistics was in multiple stages, like I said, organized by size of the municipality. So we stratify the random sample of the cities of the municipalities based on the size of the municipality, so that you have good representation in the samples of small cities, mid-sized cities, and very large cities. Okay, so skip pattern defined selected. Recife was not included because we've done an evaluation of Recife. We include the only city that where the program is being expanded to. Okay, city of Recife had the program for 20 some years in a modified version, that is. And after the government at that time decide to incorporate PACID into the city of Recife municipality, it became a public health program, and now state was implementing it. That's different. So systematically sampling 80 municipalities, cities are a sampling unit, but subject a unit of analysis, remind you. Reanalysis of implementation stage of ACP municipality selected and sample. And if unbalanced, resample within strata of implementation stage. So you have large cities, mid-sized city, a small city, you random sample the cities within that. 80 cities were randomly sampled out of 185. And then you random sample the households inside the cities, okay? And then you interview the adults in the household. That's how we did it. Here are the selection of the 80 cities that were selected randomly. Igaraçu, I mentioned, was there. You see that? That's a small size city. Fernando Noronha, that's what beautiful beaches are on the island, middle of nowhere. So here are the cities. Maybe it's too much, but we actually, when you get people to go to the household, we observing them through satellite. I'm not kidding. Okay, that was in 2003. I was in innovation. We were able to actually, through the satellites in Rio Grande do Sul, follow and see if the people are pinging them, like a ping, electronic ping, to see if they're on the streets and the household. So here is a little bit of the sampling by region. Okay, number of municipality, percent municipality by region, number of municipality sample by region. Okay. Here, again, is by the size of the municipalities. You know, then we have total municipalities, very small and small cities. Majority were in between 20,000 and 50,000. So you did a proportional kind of allocation, trying to get a proportionality, a little bit more on the 20 to 50, less than 50,000, a little bit less on the more than 100,000 and less than 10,000. Here are the states. Here are the 80 municipalities selected in blue. They was a random sample. You see, these regions are very different. The one on the very left here, that's the Sertão. The one on the Lithuanian coast, that's Mata. That's Mata Atlantica. It's very wet. It's sugarcane, very different population, very different habits. The one in the middle here, the big blue here in the middle is Agreste. That's an antiplan. That's a mountain type, and temperatures get very cold. There are 3 cities here. They get close to 0 degrees centigrade in the winter because of the height and the wind. Okay, and that's very dry. Incredible food, different than everything. And then you have Sertão, which has a nearly desert-like temperature and people. The people are different. The people in the Zona da Mata are very typical Northeastern from the Lithuanian coast, a lot of African influence in the culture and the way to go in the makeup of the population. So all of that influence how you are. So you have a very long state that has very different environments. But you can see that the sample did a good job in picking a lot of the regional differences. Here a little bit of meso-region of Pernambuco with the municipality sample. And you were able to actually follow, and this is one of the photographs of the satellite. You knew exactly when people are out doing the surveys on the household using that type of, the regions, the micro regions. Then where they went, we were able to all real time and during the day to follow up where they went with their car to get the collection of the information needed. Okay, routes for data collectors, everything was planned. That's the budget, was 1 million reais. Pretty decent amount back in 2011, right? 2010, more or less. Here are the team that did this evaluation. I have to recognize the folks on the team, the consultant, Dr. Romes here from Unifesp, some of the other folks, and the participants are the program in Pernambuco, that's PACID, that's the ACP in Pernambuco State, IMIP, which is University and a Hospital System, Ministério da Saúde, and the project GUIA, which is the project that I was head for many years, being the head of the Prevention Research Center, the Centers for Disease Control and Prevention. And other research institutes are also involved, we should accommodate. So you have a pre-test, post-test type of control group design, so to speak, but it's delivered in such a way that becomes a stepwise analysis type. So a priori stratification, so the strata becomes a fixed effect. A priori stratification within groups or strata, we're talking about random effect. I'm not going to get too much into that because of the interest of time. But you need to make decisions when you do analysis like that. You have to have a statistician on your side to help you to understand what should I treat as a fixed effect and random effect. That's not the place to learn about that. That's a regression, multivariate regression type of setting. So you can learn, but think about it. The clusters introduce random effects, just the fact you're sampling on clusters, okay? Just think about that. Terms, conditions are the source of random variation. Fixed effects, single random effects also are used. Mixed effect when you have both the fixed and the, so we use mixed effect because you have real effect like single fixed effect factors, and we have random effect giving the site, each site was selected as a random effect. So you have all those no Gaussian scores, general linear model, generalized. We use generalized and a mixed model. Two sources. This is more for your statistician. Two source, group and member generate two source of variance at the group level and a member level, right? You remember between, within. So therefore, we use generalized mixed model to accommodate the random effect. We use the SAS-Prox mix in the analysis. A little bit of that. So here, this is modified from hospital epidemic from Singer. I just say these are my 7,185 members collected in 3 points in time in Pernambuco State from those 80 cities in the first survey, 80 cities in the second, same 80 cities, but random sample of their population in there. So it's a cross-sectional survey, okay? Average of 14 to 67 members per city. The largest number was in the city of Caruaru, a very famous city in Pernambuco State, with 67 members. Member level outcome is the physical activity score. I'm going to call this PA score. And the question is, what does an equation look like if the city is modeled as a random effect, remember the city is the cluster, use a single and multiple equation representation. So this is for your statistician to remember. If you do that, you end up with something like that. There's two sources of variance that has to be accommodated in your mathematical model, okay? And it's accommodated by the U sub j term. I didn't put the x's here, just the term. And the U sub j is actually A sub j and E I sub j. For each j subject E independent member inside E. It's like the general E. Okay, so this is for the statistician. Random coefficients briefly. Let the regression coefficients vary from group to group. So that's what I'm doing. I'm allowing the coefficient of the effect of the intervention vary group to group. That's a J group. Okay, group J can have a higher or lower values on A and B. Okay, A is the intercept and B is the main effect. Okay, so here a little bit of that. You have 3 levels of variability. You have 3 distributions. Okay, and the covariance of these 2 guys is going to give a measure of the intra-class correlation. It's affecting your covariance estimate. So added elements of complexity, treat time as an interaction with intervention. That's how I did. Remember I mentioned that in the regression discontinuity and the time series analysis. It's similar. You have an interaction between time, when it was measured over time, there are 3 points in time. It matters because the intervention is being offered. Those who have a longer period of time will be affected by it. Treat time as a design variable to adjust for its effects. We have a factor of time enter in the model. A priority stratification strata is a fixed effect. So the stratum is fixed effect, but the city is enter as a random effect. Okay? Doing random coefficients are more for your statistician. Biases, everything is possible. I did not eliminate bias because this is a quasi-experiment. It's not a randomized design. It's not a strict control of the delivery and the offering of the intervention. Actually, I'm documenting the variation of the delivery of the intervention. I'm counting on it. And therefore, I'm measuring that to create a typology of quality of implementation. The X5 is the one that has perfect implementation, took the money early, spent it wisely, train their people, hire their people, get the people excited to come and get them participate in the academias. So I have many of cities who did that. They are the X5s and the others are X1. So I have a variable that captured the intervention. It's not just one variable, yes or no intervention. It's multiple variable. I mean, it's one variable with different levels, so to speak. Okay? I can treat them on an aggregate as yes or no. I have that analysis too. So these are the advantage of disadvantage. Main advantage here, it may be only feasible way to evaluate the program. I could not randomize. Expand slowly over time, so it allows you to create natural comparison groups. There will be always tons of communities after 3 years of implementation that do not have the intervention. Effectively address bias that plague all quasi-experiment. The main bias in quasi-experiment is really not knowing how the intervention is delivered and whether you have a true control group. Here I do. Okay? Can be stronger design over time, becomes time series with control group, varies baseline and follow-up. I could have turned that into a kind of a time series. So I had a different way of collecting the data. Every 6 months or something, we have like, maybe 6 months would be like 6 data points or 12 data points. That's a lot of work, but the sample would need to be smaller. I could, with the money I had, maybe do something like that. Can incorporate group level effect appropriately. I think we can, because it shows that cities who have in the same group, group 5 is the one that most municipalities are in the 5 level of intervention 5, level 5. Expensive, this is a disadvantage, may be inefficient compared to other possible design. It can be cost a lot. It cost $1 million to do that, $1 million reais, sorry. Back then was like 1 to 3, so it would have been $300,000. That's pretty expensive. Larger variance, because we have the way we collect is the city level create a larger variance, so you have less chance of showing the effect of the intervention. It's hard to decline the null hypothesis when you have larger variance. Remember, the test statistic, the variance is always in the denominator. The smaller the variance, the larger the test statistic, the smaller your p-value. Okay? Needs large sample, large effects. Natural experiment may fail because intervention occurs after a long interval, risky investment of time and effort. It could be that the true effect could only be extracted after 5 or 10 years of, I don't know. But I knew from the early evaluation that the academies had an effect. But the problem that was unknown is that some of those communities who investigated our first study, which was a case control, the academias back then had been there for 20 some years. So maybe there will not be enough time. Maybe this evaluation reflects that there's not enough time for many of them. These are the results. Sorry for being so small. Okay, goodness, I have to put my glasses here. But here you have a little bit of the general description of the community in terms of their median income. A lot of that was adjusted in the analysis because that affects the ability of people in cities to structure. And here on the right-hand side, you cannot see well. I'm so sorry, folks. 1, 2s, and 0, 4. That's the classification I mentioned to you, the implementation. Many communities here are at the level 4 or 5 of classifications. Many are 0, 0, 0. There's nothing going on in the first, the second, and the third measurement. Okay, you see what this last 3 columns are doing? I will blow that up so you can see it. Maybe I cut this table in half and blow up this font. Fred will do that so you can see that. That's the classification of the implementation that I mentioned to you. I create a typology. So you could do something like that, 1, 2, 3, 4, 5 level of implementation. You see here. So in 2011, absolute majority of them had not even constructed or initiated construction of the physical space where the academia could be implemented. Okay, you see that? That's the blue, 59.5%. Over time, you can see that more academias were being built with the money. So 16.4% had construction, but no officially organized activity going on. So 16.4 plus 59.5, that's a lot. That's 60, 75, 76% more or less of the, in 2011, of the cities did not have any academia going on. Only about 24% had some work done. Their construction completed activity was done by the surveyor, but not for all 3 successful years, only the first year. So by the third time we measured 3 years later, 25% of the place had construction completed way back, activities going on for 3 years straight. They had activities going on for straight 3 years. So that you'd expect the most effect coming from those, and that's what they came from, most of the effect. So that's a very detailed, I have more detail than that, but that's at least a classification of the typology of implementation. You can see, okay? The key results I'm presenting in this simplification, just showing the proportion. This is the proportion of those reaching the leisure time physical activity level recommended that improve your health. So the people reaching that level is present as percentage. Those reaching the level, all of them reach the level. I have 26% of the people where construction and activity are going on for 3 years already. 27%, 26, nearly 27%, had reached the level recommended of leisure time physical activity. Whereas those cities with no construction, nothing, their city, the whole city was only 19.6% were doing recommended level of physical activity. Okay? Remember, I had more effect than that, but these are the ones that are significant statistically. Given the random effect, the variance became very large, and it's hard to show significant change. Okay, here's a little bit of how that is reflected in the adjusted odds ratios. You see things that you expect, and that's reassuring in the analysis. You expect that education, age, and socioeconomic do affect positively the level of physical activity shown in many different research in the past. The younger tend to be more active, the more educated tend to be more active, and people more higher socioeconomic tend to be more active, as well as single people, as opposed to married people have all the obligation. So you can see that here. It's proven. So that's to say this is not a biased sample over time of the population, because it's reflecting known association between leisure time physical activity and major demographics of population all over the world. Okay, so that's reassuring. That means my samples are not biased. It was a good, simple, random sample over time inside the design to evaluate the intervention based on a quasi-experiment. Here, on the other side, I have continuation of table 2. You have the same finding you had here, but now present as odds ratio of construction after 3 years is 1.09 overall, okay? But it's bigger. I didn't do, well, I did over here. It's much bigger for women, okay? It's much bigger for women. So this is overall. So if you eliminate the men, just focus on the women, you're going to see a effect. Now, actually showing here, because it's going off focus. Fred, can you help me here?
Yeah.
Maybe, maybe I can push it. No, I can push it over here. Give me a second, folks. I want to go off the table a little bit. No, it's okay.
Just to spread it a little.
Yeah.
Because of the,
Yeah. So you can see here that the effect of having construction completed in activity for at least 3 years compared to not having that completed or less than 3 years, you see that the variation here, the different levels. Okay. So you can see for women, that's women, the last 3 at the bottom, the last 3 rows at the bottom. You can see that went from 1, that's the no effect. That's for no construction. So I'm contrasting people have completed the construction, have activity going on for 3 or more years with those who are not in the group with that there are ongoing construction, no ongoing construction whatsoever. They have nothing, basically. So that value for the odds ratio is 1. And then by contrast, those who have 3 or more years is 1.46. And it's significant, does not include no hypothesis. The construction completed in activity, but less than 3 years of activity, is 1.09, with a confidence interval including the no hypothesis. But then I have 2 test statistics in addition to that. I have one that shows the effect of 3 or more years of physical activity through the ACP program, construction completed, everything done right, that's 1.46, and highly significant at 0.03, I think. Okay. However, the next level was not significant by itself, but the trend, the p-value for the trend from 1 to 1.09, 1.42 is highly significant at 1.02 or 03 or something like that. So you have 2 ways of saying that. So the bottom line is the academia in Pernambuco, the program expansion in Pernambuco shows it's not only a significant from a public health standpoint, because it increased the percentage of people from 19 to 27% who are actively at the desirable recommended level for health. But more importantly, the numbers went up, especially for women and poor women. We did an interaction with education. And if you stratify in education, you're going to see that's even stronger. I didn't have it here for poor women. So remember what I said to you, the literature worldwide at that point showed that women exercise less than men. Women who are in low income exercise nearly 0 because they either work or take care of kids or doing something. And this program were able to actually make poor women to be more active than the men. Okay? So that's a very powerful effect of this program. So it's doing not only increasing physical activity levels for the whole population, but especially so for poor women and older women. Actually, the absolute majority of those women are older women who don't exercise anywhere in the world. But if you go to Recife over the past 30 years and look on the beach or in Jaqueira or in all the called polos, the sites, you're going to see mostly middle-aged women exercising every day. Okay, so that's an incredible effect of the program. We prove it, and it published in American Journal of Public Health. And after that, the Minister of Health took this paper and the original paper and the other ones we done in the academia and justify the creation of a program. Okay, that was in 2010. I think the Minister of Health at that point is somebody from São Paulo, and the No, the Minister of Health was no. It was no from Pernambuco. It was Humberto Costa. Humberto Costa was the guy who initiated. But the other one who came after him when they did it nationwide was from São Paulo. Not Serra was later, like in 2012. This is 2010. The guy who substituted him from São Paulo, I think was no, it's from São Paulo, senator. He's still pretty much active. He's from the PT or one of the Ministro da Saúde. Humberto was from Partido dos Trabalhadores, and the other one too. So the good thing about this intervention, this program, this evaluation, is that they did not bring politics into it. They went for the science, for what works, what doesn't work. And that is very important because usually in many places in the world, the dichotomy between politics affect what is right, what is wrong. So I can say that at that point in time, the Minister of Health was mostly people linked to, in high position, to whatever left-leaning orientation they have. And at state level, and they've done an excellent job at that point. That's a fact, okay? It doesn't matter what I believe or not, is what they did and what they did with me. And it was outstanding. And because of politics too, a few years later, I had the displeasure of learning that a new mayor was trying to kind of minimize this program, diminish the investment on this program at the city level. Padilha, yeah, Padilha was Minister of Health. He's from São Paulo. When the program was expanded as Academia da Saúde, became a nationwide program. It's not just the academia, there's more other elements, social, it's more ample. Academia da Saúde. They turned Academia da Cidade, Academia became Academia Pernambuco. That's the one I evaluate both. I evaluate the Cidade and the Pernambuco. And then they took those two papers, and then I was there in a ceremony in Brasilia with Minister of Health, myself, Deborah, everybody there was, and he created the program. I mean, convinced the Congress to create a budget item and create a national program. That's a law. There's enacted a law. Okay, so that was a good story, folks. That's why I wanted to think about evaluating public health programs, evaluating healthcare strategy, evaluating anything. Just evaluate. Use these lectures. I'm a perfect teacher. I may miss a few things, but you have good material to good start on this. What time is it? Am I going off time too much? Huh? Yeah, I promise I'll finish around here. So the other pearls I have to say about this evaluation, do I have another evaluation to show you? I hope not, but maybe so. Let me take a look here. Example, meta-analysis we went over. Well, I mentioned to you that hold there for 10 minutes. Meta-analysis is very, very important. Why? Even if you have lots of good evidence-based studies, meaning evaluation of effectiveness and efficacy, sometimes you don't have enough, but you have a lot of studies trying to evaluate an intervention or a strategy or a new treatment that are kind of borderline, and you wonder, should I use that or not? A meta-analysis is right for you. A meta-analysis will increase the power that you don't have. It's almost like artificially inflating the sample size of one single study. And that's what you're doing with this type of study. And I've done two recently funded by my grant with NIDDK, which I'll put the numbers of those grants as well as the one of CNPq and that. When Freddie sent to you those lectures, I want those grant numbers there, okay? So you see it. So here's a quick meta-analysis on very simple concept. Does information technology, health information technology, an app, a combination of app with cell phone use to the app, scheduling through cell phone, dashboard of physician, all kind of possible combination versus traditional treatment of diabetes, just asking patients to do the self-care, which is already advanced, or traditional just, glucose monitoring, take your medication or take your insulin on the right time, okay? Does it matter? So we evaluate that. We evaluated that in two different ways. This is the evaluation of cardiovascular risk factor among patients with diabetes. There's another meta-analysis that was done on the effect of HIT on diabetes itself. This is a continuation. It was shown to be very powerful. as good as medication. That means once you control for the medication, the HIT itself improve your reduction of A1C by 5 or 7%. Okay, here I'm looking at the, does it also improve cardiovascular events among diabetic patients? That's a very important question because 80% of the diabetic patient long-term type 2 will die of heart attack or a stroke or kidney failure that the heart contributes to it. Okay, so I'm going to skip all of that just to say to you, this is what was evaluated. 6 cardiovascular risk factors, and we synthesized the findings of HIT, health information technology, on primary cardiovascular risk factors. These are the primary risk factors: blood pressure, systolic, blood pressure, diastolic, high density lipoprotein, HDL, low density lipoprotein, LDL, triglycerides, TG, and body weight. Okay? Here is how you do a meta-analysis. You go and screen the literature like a systematic review, which is another lecture that I usually teach together with meta-analysis. And then you stream that, you kind of filter around the things you like to show. For instance, this meta-analysis was only involved randomized clinical trial. So I eliminate a lot of observation and quasi-experiment. Okay? So record screened, record excluded based on what you did to document all of that. So you, out of 463 articles we extracted on this issue, we're able to evaluate in the end 27, okay, for the effect. And 21 of them had, out of 23, 27 study had focus on systolic blood pressure, but they had 23 estimates. So it's not 21 studies and 21 endpoints or dysphasias. It's 21 studies, 23 dysphasias, endpoints, outcomes. Okay, so this is how we came. So results of this meta-analysis, you end up from a total of 3,290, you end up with 463 participants included. 6 studies that were there. 20 studies were mobile phone-based intervention. 7 are hybrid, mobile phone primarily, others included. 3 were web-based intervention, only the web. Patient will have to go to web kind of a base site to do their interaction with the physical physicians or the physical physician systems. 4 were just text and SMS message, and 1 was video talk. Okay, and they're all adjuvant. And they are not the main intervention. They are kind of a helpful intervention, but they are analyzed indirectly and separately. 10 studies.
Was only 6 studies.
What?
6 studies only.
Where we see 6?
7 point.
6 studies in the United States, 9 from Europe, 6 from South Korea.
57, man.
Yeah. Let me see. 27.
57. That's sum up 21.
Yeah, well, there's eliminations. Let's see, 6, 9. Some of them were kind of repeated. I have to look it up. The paper, there's a paper there, you can read it. The editors will pick it up. Maybe I have a typo here, maybe not. Maybe there's a combination of the estimates, remember? Some of them are 14, studies on LDL, but there are 17 estimates of LDL. They're kind of a... So 23 studies had even gender distributions. That's how you describe the studies that you investigated, that you summarize. And then you end up, that's the real deal here. This is like effects of HIT on systolic blood pressure in diabetic patient. 0 means 0 effect. You can see that individually, most of the studies were around 0, right? But some of them were way away from 0. They're closer to minus 17.5. So the next jump is reduction of 17.5 in blood pressure, in systolic blood pressure. Okay, one study was like a reduction of 20-something millimeter of mercury in blood pressure, but many of them are close to 0, but many were not. Between 0 and 17.5, the middle would be about kind of a 9 or 8. And these guys here on the left, there are 4 or 5 of them are like 9 or 8, reduction of 9 or 8 millimeter of mercury. So do they really have an effect? So the average effect is reflected by this little losange at the bottom here. You see that little losange with a red thing over here? Okay, that's your average effect, and it does not include the confidence interval of 0, 0. Okay, the confidence interval does not include the null hypothesis of no effect. It is a true effect. You follow that? That's what meta-analysis does. It takes the average, a weighted average, and accommodate different level of variance and heterogeneity of the studies through a hedge fund estimation. And you say, hey, the average reduction, it's pretty decent. Okay, the G says minus 0.039, going from minus 0.6 to minus 0.15. Okay, that's systolic blood pressure. Same thing with diastolic. You can see the effect at the bottom. Because I'm not teaching the meta-analysis lecture, I'll give it to you. Fred's gonna give it to you. You have a full lecture there. You know how to do that later on after you study the lecture. But you see a result of one example. I wanted to show to you this, the beauty of it. If you look individually, each study, for those who study true epidemiology, Rothman. That's the Pope in the Bible of epidemiology. He has a section that was 40 years old now that he looked something like that to say something's fishy here. I need to do something. He was actually insinuated we needed to do a meta-analysis, and he wanted to know the proposals of that meta-analysis. Because look at this one here, okay? Here you want the effect of HIT on high-density lipoprotein. That's a good cholesterol. You want them to be higher than 0, the change, right? You wanted them to go up. And the absolute great numbers of them are above 0, but you don't know what their real value is because their confidence interval, this line, the horizontal line, include the confidence interval, include the null hypothesis of no effect for all of them, except for one, the second study for Hummel. It was a very powerful increase in HDL, and the confidence are very tight. They have a very large sample size. So that it tells you this issue, those studies were sample size, actually. Okay? So it looks like the majority was showing some effect, but they're closer to 0. But there are some effect. You talk about something that's very powerful. If you change 0 to 4, that's pretty high for high-density lipoprotein. So the real effect is this one here. Difference in mean is 3.7, 3.78. And the confidence interval does not include the null hypothesis of 0. Okay? It's between 3 and 4.56. That's your average effect. So that's what the meta-analysis does, folks. Very powerful. This is published. Same thing for HIT. HIT, I think, did not show, triglycerides. So it shows an effect for systolic blood pressure, diastolic blood pressure, high-density lipoprotein, low-density lipoprotein, all significant effect. Okay. Can you question me? You say if the confidence interval include the null hypothesis, means you have nothing. Are you talking about which confidence interval? I'm marking red, and you can see that the average estimation of what should be the confidence interval if all these studies were done together. That's what meta-analysis does. If all the patients involved in those studies were all in one single study, that's what a meta-analysis does. It emulates and mimics what a large study could be. Okay? And it accommodates 2 levels of variance. Usually you introduce a random effect. And there is also measurement heterogeneity. If the heterogeneity is very bad, you should not trust your meta-analysis results, even with the random effect. So I had that done too. I don't show that. It's called funnel evaluation, and a lot of other statistics we use it. So the meta-analysis is basically averaging a weighted average of the real effect for each individual study and increasing the sample size artificially, and therefore it diminishes the true variance that you have. Okay? So in the mathematics of it, in that lecture, you can read that, Leonardo. Okay? So that's this value here that you see here. The average value here is minus 8.147 for low density lipoprotein. That's a reduction of 8 millimeter of mercury. That's not blood pressure. I think is a milligram per deciliter. It's milligram per deciliter of low density lipoprotein. It's a reduction of minus 8.1415 if you round it. And that reduction is an average across all the other values. There's one value here is minus 24. You see that? It's a value minus 11. Minus 11. So all of them are, there's no value here called zero. All of them are saying, hey, there might be an effect, but the standard errors are very large. Therefore, the confidence interval for each individual study includes a null hypothesis of zero effect, absolute majority. But if you do it together, if you do a meta-analysis, it unearths what the truth should be. That's what meta-analysis is all about. But you need to study the math and the mathematics of it, and just choose to believe it or not. I do, because I know how the sausage is made. It's very careful and inflates variance. This variance is huge, okay? Because it has a huge random effect. And there's another stat I'm not showing here, that if it shows too much heterogeneity across studies, that means they're not comparable, these studies, because something went wrong in the intervention or with the outcome measure, too much heterogeneity. So you should not believe on that averaging, weighted averaging of the true effect. So there's a lot of careful consideration when you estimate this. This is all in the paper. You can read the paper, okay? So this average effect for triglycerides shows, even the average effect, it shows not significant, even a meta-analysis. So I have to accept that HIT among diabetic patients will not going to help you to reduce your high triglyceride. Okay? HIT on body weight, it was, p-value was not significant either. So it did not affect your body weight. Because the HIT, health information technology for diabetic, include nutrition, include physical, include a lot of stuff usually, many of them, in addition to monitoring your glucose better. That's another way to represent, but here I'm doing another distinction. On the bottom is the overall analysis that you saw a little bit of that on the table. On the top, I'm doing just the effect of HIT on CVD, comparing HIT and plus standard care intervention versus standard care controls results from the subset meta-analysis. So from the total meta-analysis, I took a smaller subset, and looked only at the 6. You see there are 6 studies only here, 5 studies, 4 studies, 4 studies. I took a subset that could compare separately just HIT standard care versus standard care alone. And the other one is the overall effect, not separating them out. And here I replicate a little bit of the same findings. I have effect, and some of them becomes even stronger. Okay? So meta-analysis is a powerful tool to unearth the truth about the relationship. They're still doubtful, especially intervention. This is only randomized trials, so they all have pretty decent design. But many of them are not powerful statistically to do that. Their sample size was not too good. Maybe people miscalculate, maybe their prior estimation, because you remember to calculate the sample size in the denominator, you have to have your estimation of variance, okay, the combined variance, the pool variance, and you have on the top to have your estimation of the effect of the intervention. That's coming from prior study, pilot study, usually a pool study, or an observational design, a case control, a cohort, not too good sometimes. So their numbers they use to estimate their sample size may be probably the reason why they end up as a sample size was not sufficient to demonstrate this effect, okay? Or the effect is actually small. For instance, for the effect on diastolic blood pressure is very small. It's minus 2.2. So if you have a blood pressure that's 15, you reduce that to about 13. You see that? It's a decent. It's statistically significant and clinically significant, but not highly significant clinically. I'd rather reduce more. So when you have a small effect of the intervention, you need a larger sample size. So many of those studies are not too big in sample size. So in the discussions, you see the effect of that. So I want you to finish to say to you, you have covered a lot of things in these past 6 days of lectures. It's 2 weeks, but we have only 6 days of lecture 3 hours a day with breaks in between. We cover, I think, almost every possible design to evaluate any kind of intervention, individual level, community level, clinic level. You learn about, again, about randomized design. You learn about a review of observational design, case control, cohort study, cross-sectional studies, and then you learn about randomized design, individual level, also individually controlled randomized design, the control cluster trials, the variation of that, the stepwise design, then all quasi-experiments, including time series, which is kind of a natural experiment, then regression discontinuity. You also learn about difference in difference and variation of the theme like I presented today to you, okay? And the pragmatic trials I gave quickly today, but I gave you a gist of the pragmatic trials. 2 examples here from São Paulo. Dr. Rome was not present, but it was you who wrote with me those articles. 2 other of your colleagues were first author and people who you supervise. So you have a lot of examples on those. I'll make sure we review those lectures for formatting and make sure we put the right sources of reference and citation. More important, acknowledging the grants of the program, okay? There's a supplemental slide. I mentioned to you, Leonardo, that we look into other things, risk of bias assessment. Only allocation of concealment was a kind of possibly bias. Everything else is in the blue, means low risk. So I believe in that meta-analysis, but there are ways of evaluating. If a lot of those things I mentioned here came orange or gray, I would not accept the value of that analysis, okay? There's also the funnel plot, which is not showing here. I'm sorry. I'll double check how we make this to work for you. But the funnel plot tells you that the standard difference means it's an acceptable range of heterogeneity. Also, publication bias, we'll look into that. It's here. You can read the paper, and more important, heterogeneity estimation, okay? So truth is, meta-analysis is a complementary of evaluation of intervention, because another way to say, hey, I have 5 evaluations, but they're not too clear whether I should invest in this new intervention. Let's do a meta-analysis. Maybe I'll find even more intervention in the literature in addition to those 4. Maybe just do a meta-analysis of 4. Say if they together show some effect, okay? If they're all showing the same direction of association, that means the effect is coming in the direction that you expect the intervention to have an effect. But they may have lack of power, and therefore I need to do a meta-analysis. So the lecture on meta-analysis, not the example I gave it to you, the lecture will be given to you. I use my own example to give you a little bit of trust in me that not only I talk about theoretically, I've done it, all these evaluations, okay? And made a lot of mistakes in the middle and trying to bring as much knowledge to you as possible on that. So good luck and thank you. You've been great audience. No questions here except for the people on the classroom. Yeah, Professor Luiz Ramos is going to say bye to you in a proper way.
Hi, folks. I want to thank Dr. Simões for this great series of lectures that certainly will enlighten people involved in evaluation of programs. Dr. Simões has been with us many other times, and we are grateful for that. And I hope everybody had enjoyed this series of 6 lectures. They are all being in the drive for you to check and see it again. And I just thank Dr. Eduardo for his time and knowledge. Thank you. Estava desligado aqui.